Our next session today is on the General Recommendations Work Group. Dr. Paul Hunter is the work group chair, and he's going to get us started.
Hi again, I'm Paul Hunter. I teach public health students at the School of Medicine and Public Health at the University of Wisconsin, and I consult for the City of Milwaukee Health Department on communicable disease and immunization issues. As work group of the chair of the General Recommendations Work Group, I'm here to provide context for Andrew Kroger's presentation about the recent and upcoming changes in the best practices guidelines. The work group meets monthly to achieve the goals and objectives listed in the terms of reference. These include revising the general best practices guidelines for immunizations as needed, or for some sections, at least every 2 years. Addressing other general vaccination issues as needed, including emergent issues that don't fit into the terms of reference for other work groups, is also part of what we do. In short, the work group is a gathering place for people that like making connections between disparate disciplines in order to come up with practical interventions that help clinicians and their patients. Previously known as general recommendations, the general best practice guidelines provide expert opinion and, where available, evidence for issues in clinical practice that cut across multiple vaccines. The up-to-date version of the guidelines is available at the ACIP website under Comprehensive Recommendations or directly via the URL at the top of this slide. As a consultant to public health nurses who administer thousands of vaccines a year, I find that the best practice guidelines are where I should have gone first to answer my questions that aren't answered by my standing orders. So I encourage you to go to these guidelines also with difficult questions. In the recent past, sections of these guidelines were presented for discussion over a series of ACIP meetings before the entire set of guidelines was voted upon by ACIP and published in the MMWR. Today, Andrew Kroger will review recent errata and updates that have been added to the guidelines on the ACIP website. Dr. Kroger will also present for discussion the draft addition to the best practices about healthcare personnel who themselves have precautions or contraindications, but who may nonetheless administer those vaccines to patients. There are no votes on the guidelines planned today. I want to thank the non-federal subject matter experts and liaisons on the work group listed on this slide for their contributions to updating the best practice guidelines. Thanks.
Okay, so thank you. I'm going to do three things. I will give some background into the general best practice guidelines for newer ACIP members and the group. I am going to cover those revisions / errata that have already been posted to the CDC webpage. And then I am going to discuss a specific topic for discussion by ACIP. And so to begin with background, you just saw this image of our webpage and the website. This still looks the same, even though some of the websites upstream from this page look a little different. This one looks the same. The General Best Practice Guidelines for Immunization is now an online document. It does not exist as an MMWR document anymore. It is best practices of the ACIP, and it is a CDC guideline. So this is how you can access this information by clicking the URL at the top of this slide, and it'll take you to this page, and then you may notice that underneath the bar Comprehensive ACIP Recommendations and Guidelines, you can see a link to the General Best Practice Guidelines. When you click on that, it brings you to this page, which is the main page, the HTML version of the General Best Practice Guidelines for Immunization. All of the subject headers now exist as links, as you can see with the gray banners in the center of the slide. Introduction, methods, timing, and spacing. Just for clarity, I'll show you the rest of them. Contraindications and precautions, preventing and managing adverse reactions, reporting adverse events after vaccination, vaccine administration, storage and handling of immunobiologics, altered immunocompetence, special situations, vaccination records, vaccination programs, and vaccine information sources. So each one of these has a gray banner that you can click on and access that individual HTML file for that section. This product is available for continuing education. Continuing education is renewed on a 2-year cycle. So we want to make sure that ACIP is aware of this online document at least once every 2 years before we revise the CE. And so by clicking on that link, this will take you to all of the registration and continuing education information. Every word of the general best practice guidance, or guidelines, I should say, exists not only as HTML, but as a PDF file. And so you can see where you click on the PDF version of the document. And I'll make the point that there's a PDF for each of the individual subtopics as well. Once you click on the banner, it'll take you to a choice of HTML or PDF. And the cover of the PDF document, it's a print-friendly document, looks like this. One of the important, as a transition to talking about errata and updates, I wanted to show you where you can find it. It's just above the block for continuing education. If you click on this link, it will bring you to every single update that has been made to this online document since April of 2017, barring some punctuation and other typographical issues, but it'll take you to all the other changes. And so to find this information, you would click on this link, and it looks something like this, the list of errata and updates. The entries are indexed by the date by which they were posted. So the most recent set of updates were made on September 20th, 2018. For each entry or update or errata, you can see that there is a page number listing. You can see that there's a link to its location in the PDF, or a link to the PDF for that particular section, I should say, as well as a link to that section as an HTML version below that. A listing for the specific table, table 3.1, you can see that first listing, and a description of what the change is. So now I'm going to kind of run through some of the important ones that I wanted to make sure that ACIP was aware of. Note that these are either harmonizations of CDC recommendations, ACIP recommendations, which have already been voted on, already cleared through CDC. They may be interval issues that have already been posted to our CDSI, Immunization Information System Registry webpage. So these changes have already been made to the document. So I'm going to index this discussion by actual disease topic from this point on, or vaccine topic from this point on. So the first fixes, pertussis-containing vaccines. We made a clear statement of the minimum interval between dose 3 and dose 4 of DTaP, which really varies whether you are looking ahead to scheduling the next dose or counting a dose that's already been administered. We call that prospective or retrospective. We have a statement that the grace period can be used for both of these scenarios. It's a 4-day grace period. And so basically this is kind of, for this presentation, I place in red the date in which this addition was made. This is also the way that CDSI is programmed. pertussis-containing vaccine change is that 4 precautions to DTaP have been removed. These 4 are no longer considered to be reasons to withhold the next dose of DTaP. No risk-benefit indication or no risk-benefit should be done. They are no longer precautions. They were considered to be related to use of wholesale DTP and not relevant to a cellular pertussis vaccine. These changes were placed on the website between July and September of 2018, but they were actually published in the CDC ACIP recommendations back in February of 2018. We did place minimum intervals for serogroup B meningococcal vaccine on table 3.1 in the timing and spacing section. This is published on CDSI business language, the CDSI webpage, the business language for registries. And so now this also appears in the general best practice guidelines as of September. I'll make a point that you don't use minimum intervals on a routine basis. These intervals, though, are very important for providers to have in certain circumstances where errors have already been made, mix and match of brands. You need to have the minimum intervals. Now they are posted on the CDC webpage, and they've been in CDSI as well. Hepatitis A, there's 2 topics that I've changed. I have updated the dose of immunoglobulin for hepatitis A prophylaxis. So that's been updated. I've also discussed with partners in FDA about the fact that even though we've adjusted the dose of IG, there is no need to adjust the interval to next subsequent MMR or varicella vaccine, so that remains the same. We've also made a change in the vaccine administration section to specify that IG and hepatitis A should be administered in different limbs. This is related essentially to the volume of the immunoglobulin product. It joins 2 other examples of this, TIG and tetanus-containing vaccines and HBIG and hepatitis B vaccines. We added some long-standing CDC published recommendations for varicella vaccine to the general best practices. A family history of altered immunocompetence has been a published contraindication to varicella vaccine since 2007. It now appears in the general best practices table. I only have varicella on this slide, but we've also added this content for MMR vaccine because it's also published in the MMR vaccine specific recommendations. And then I have footnote explaining that the concern here is with congenital immunodeficiencies, and the noted intervention is to screen your patients through histories of first-degree relatives or use of laboratory evidence of a congenital immunodeficiency. It is generally presumed that a congenital immunodeficiency will be detected prior to a decision to use varicella vaccine or MMR vaccine anyway. The other precaution is use of aspirin, or the other change is a precaution, use of aspirin or aspirin-containing products. And so this is less a vaccine precaution. It's more of a recommendation, in a sense, to avoid giving the medicine 6 weeks after the vaccine has already been given. So that doesn't really meet the definition of a vaccine precaution. So that's a precaution. And then we've also added the precaution regarding receipt of specific anti-herpes virus antiviral drugs 24 hours before vaccination, with the flip that you should avoid use of the anti-herpes virus drugs for 14 days after vaccination. And then for zoster vaccine, we have made a change in the vaccine administration section of the general best practices. With all the other vaccines, there is a table in which we list vaccination injection volume. However, unlike the other vaccines, for which we allow administration of additional volume, since vials are often overfilled, we specifically specify 0.5 cc's per the package insert as the volume that should be injected for for Shingrix, I should say, vaccine specifically, RZV. Lastly, as with varicella, we added the contraindication to LAIV that antiviral medications given within the influenza antiviral medications within the previous 48 hours is a contraindication to LAIV. In this circumstance, it's really not a feasibility issue, not a precaution. There is an alternate vaccine that can be used. So those are the changes that are already posted, and you can find all of these changes either by going to the errata page first or just searching for them in the document, in the online document itself. So now I want to kind of, for discussion, present some language that we would like to share with ACIP. This language will need to be cleared through CDC before it is placed on the online document. But we have discussed this in the work group. We are often asked about providers who are well aware of the contraindications and precautions for vaccination because they're screening their patients. But what if the healthcare personnel have a labeled contraindication or precaution themselves? Can they still administer the vaccine? Obviously, they don't give it to patients that have these contraindications and precautions, but can they give it themselves, given the nature of various issues that have been presented in the past? There is no discussion of this in the general best practices. However, there is a well-known vaccine-specific recommendation published for LAIV. It arose out of concerns with pregnant healthcare providers expressing concern about administering LAIV. And to repeat what the committee already knows for that recommendation, we say, yes, it can be administered by healthcare personnel who are pregnant or have any other contraindications. There is not thought to be much environmental spread. There have been a few cases of any type of transmission of LAIV from someone who was vaccinated to someone who was not vaccinated. And that's a little different issue, but it's a similar issue to any risk to the healthcare personnel themselves administering the dose. But can all this be generalized to vaccines? So we looked at the literature related to healthcare personnel, risk of adverse reactions based on administration of the vaccine. This slide I should probably tweak this because these are not really the potential outcomes. It's more like the intervention with holding the vaccine versus administering the vaccine. But we requested these articles from CDC Library. They searched the databases Embase and all Scopus, PsycInfo, and Medline. They came up with 82 unique articles, there's a typo in the handout. I think that said 20, but it was actually 82 unique articles for which the abstracts were reviewed. There were 2 or 3 of them that were not in English. Those were not reviewed. But out of all of these abstracts, only 3 of them actually discussed this question specifically. The first was an ACIP MMWR from the 2003 smallpox vaccination program, which I think those might be well aware of it, given the low risk of smallpox disease in 2003, the risk-benefit calculation that was applied towards vaccinators of Vaccinia vaccine. It's not the same exact microbe, of course, but it is the same general topic issue. The risk-benefit calculation was tipped towards not allowing vaccinators with contraindications to be allowed to administer the vaccine, and that was based on inherent risks that the Vaccinia virus posed to persons with underlying conditions and issues of transmissibility, which we knew of from patients that had received vaccine, those that had been vaccinated. So there was that article, and then there were 2 additional articles. There was the Lira article in Developments in Biological Standardization in 1997, and Windsor Australian Veterinary Journal in 2005. The Lira article discusses the risk of vaccinating fish with an inactivated vaccine to prevent 2 types of Vibrio, a type of Yersinia, a type of Aeromonas. So this is vaccination of fish. The other article addressed the risk of vaccinating sheep to prevent paratuberculosis. Both articles did focus on needle sticks as the precipitating event, which posed the risk to the provider. The risk in the Lira article was an allergic reaction to the vaccine. It was 2 cases out of 50 needle sticks. The risk to the provider in the Windsor article was self-inoculation of the infectious agent. So based on this information, we crafted this language, and obviously the result of the summary seems to be a lack of any additional targeted direct evidence. So what we said was that providers are sometimes concerned when they have the same contraindications or precautions as their patients from whom they withhold or defer vaccine. For administration of routinely recommended vaccines, there is no evidence of risk of exposure of vaccine antigen to the healthcare provider, so conditions in the provider labeled as contraindications and precautions to a vaccine antigen are not a reason to withdraw from this function of administering the vaccine antigen to someone else. This paragraph will be followed by another paragraph that says, historic concerns about exposure to vaccine antigen are limited to non-parenteral vaccines in which some degree of environmental exposure is unavoidable, and instead of LAIV in red, we'll have the footnote to the citation. Situations in which adverse reactions from allergy or self-inoculation is likely due to reduced attenuation of vaccine virus, or the technical process of administration is complicated by vaccine recipients that struggle vigorously, leading to needle stick injury and reactions due to allergy or self-inoculation. So a recommendation in the first paragraph followed by the evidence base in the second paragraph. And so with that, I wanted to leave it to the ACIP to discuss any possible tweaks to this language. And that's really all that I have.
Great, thank you. Any questions or comments, Dr. Hunter?
Could you just move back to the next to last slide, because I think that's the pertinent one for us to be discussing. Thanks.
See one hand. Dr. Goldman.
Thank you, Jason Goldman, ACP. I'm wondering if there should be any comment in there about the obvious statement of using proper universal precautions, standard technique, to understand that if someone is using the proper best practices, there's no chance of infection or reaction or other issue.
Thank you very much for that question, because I forgot to mention that this paragraph is going to be in the section on vaccine administration. There's a whole section that discusses proper technique. It starts off with risks of needle sticks to providers. That's the kind of leads off with that, and that's it's followed by this paragraph. Then it gets into a lot of the best practices, techniques for vaccine administration, and with respect to all of the different routes, the different sites, the different needle lengths. So it's going to be in that part of the document.
Great. Dr. Moore?
This is a quick question with respect to the veterinary vaccinology. Will there be a reference that will send people who have those kinds of concerns to an appropriate resource? Speaking as someone who vaccinates calves every year for my father's cattle farm, I've experienced those sorts of needle stick injuries and didn't know quite what to do about that. So fortunately, nothing happened.
Those citations would be will be in there. I can look for another general. I don't know. I'll discuss with CDC's injection safety folks. I don't know if they probably do branch over into veterinary vaccinology. I don't know, but they may have a website.
It's just that people who are looking for that kind of information may look here, and it would be great to say, if you have this experience, here's where you should go for more information.
Dr. Hahn?
Yeah, just speaking as a state health official, we definitely get these calls. In my 20 years, I've never had a provider tell me that they got exposed to a vaccine while they were vaccinating a human, but veterinarians, and they do have more challenging patients maybe, but we do get those regularly, so that would be really helpful.
And Ms. Stinchfield?
Patsy Stinchfield from NAPNAP. So thanks, Andrew. One question that I get is Remicade, moms or clinicians on drugs like Remicade and giving rotavirus vaccine. And there really isn't anything written about that, but I didn't see that in your list here.
Right. So this is a topic that we have begun a discussion in the general recommendations work group. It would fall under altered immunocompetence because I think the issue is that is for Remicade specifically, there is the package insert states an interval for, I believe it's from birth through 6 months of age to avoid live vaccines. And CDC does have a recommendation. I know CDC guidelines or guidance, I should say guidance, is that a specialist can be consulted. That's how we typically answer that question, because we get that question a lot. An infectious disease specialist when faced with the issue of rotavirus vaccine. And we wanted to, and we have started the process of trying to come up with something general on that topic. We didn't finish it in time for this meeting. There is also the complicating issue of altered immunocompetence, because the ACIP is in the process of determining, and CDC is in the process of determining working in various partnerships to come up with some type of harmonized guidance and aligning that guidance from various partners like IDSA with the CDC ACIP vaccine-specific guidance. So there's more to come on that, and we were not able to fully pursue that issue, but there is CDC guidance already. I don't believe it is published, and I don't know if are there any rotavirus subject matter experts here now, but it's not published, but we always recommend consultation with an infectious disease specialist to weigh the risks and benefits.
Yeah,
Thank you
so
so much.
that's how it comes to me. And so then when I go to try to give them articles or things to look at, there really isn't anything published. So that would be really helpful. The Remicade package insert is about the individual getting Remicade, not the person. So it's clear you don't want to give rotavirus to someone on Remicade, but they're a parent who's giving rotavirus vaccine or taking care of a child who's shedding rotavirus for weeks, and that's what their question is. So something written. Do we need to wear gloves? Hand washing, those kinds of things would be helpful.
Thank you so much. I think that is something that we should take back and come back to the work group with. Dr. Stinfeld? I'm so sorry.
That's
Whitley
okay,
Williams?
Pat Whitley Williams, NMA. Along those same lines, and thank you, Patsy, for bringing that up, but along those same lines, there are populations in New Jersey that typically take their 1 or 2 week old babies back home to TB endemic countries, and they purposely take them to get BCG vaccine while they're there. So this issue of disease modifying drugs is an important one and certainly should be considered by the work group, because it's devastating to do that. The mother has been on these drugs, these medicines.
Thank you. There will definitely be more to come over the next year on this subject. So, Dr. Kimberlin, one last question.
As a comment to follow in this, David Kimberlin, Red Book, AAP. In the 2018 edition of the Red Book, we added language specifically about that, but a lot of it is extrapolation from what the anticipated risk is. The Canadians are doing some nice work in prospective assessments. We would welcome the opportunity to work with y'all's language to make sure that it harmonizes to the maximal extent possible.
Great, thank you so much. One more comment from Dr. Fink.
Yeah, so some labeled contraindications or precautions for vaccines, in particular those related to allergic reactions, have to do not with the vaccine antigen, but with excipients or non-active ingredients. So I'm wondering a little bit about specifically calling out the vaccine antigen in this recommendation.
So the general best practices has a section on contraindications and precautions in which every vaccine, there's a table, and every vaccine is listed with contraindications and precautions. And for all vaccines, and this is for the vaccine recipient, this is unrelated to this is the vaccine recipient themselves, if they have a history of an of a severe allergic reaction, e.g. anaphylaxis, to a vaccine or to a vaccine component, that is a contraindication to the vaccine. So we think that that's general enough to cover and is quite harmonized with FDA in that respect.
Yeah, so I think we're going to go ahead and move on. It's really important that we stick with our schedule today because we do have a hard stop this afternoon, and I want to make sure there's plenty of time for public comment. But thank you so much. I do know that for these general guidelines, there are so many different situations that the group is trying to address, and Jose's whispering in my ear multiple other things, and we'll just make sure that we please send me or Andrew Kroger an email if you have specific additional feedback or comments, because that's really helpful as they're trying to update these guidance. So we're going to move on to the flu session. Dr. Walter.
Good morning. It's my pleasure to introduce today's influenza session. So these are the members of our rather large working group. Not listed here is our fearless CDC work group lead, Lisa Grosskopf. So I just want to recap what we talked about at our last ACIP meeting briefly. At the last June 2018 meeting, we had updates for the 2017-18 influenza vaccine effectiveness, and we also had a influenza vaccine safety update at that meeting. At the June meeting, we had a presentation of the SOMNIA study, which is a multinational study of narcolepsy following adjuvanted monovalent pandemic H1N1 influenza vaccines. And then following that, we had a presentation from Seqirus on the results of a study looking at adjuvanted quadrivalent inactivated flu vaccine in young children. That was followed by a summary of the 2018-19 recommendations for flu vaccine. Since that time of the meeting, we've had continuing activities in our work group. We meet at least twice a month. Thanks to Lisa, largely, and folks at the CDC, publication of the 2018-19 ACIP influenza vaccine statement occurred in late August. We had presentations in our work group of the PREVENT study looking at the effectiveness of flu vaccine in preventing hospitalization among pregnant women. And lastly, we had a presentation looking at a study of Fluzone quadrivalent flu vaccine at a 0.5 ml dose for children aged 6 through 35 months. So there have been some changes in labeling information for influenza products. The one change that happened, I think, that was referenced this morning in our FDA update was for Afluria trivalent and Afluria quadrivalent. These vaccines were previously licensed for children 5 years of age and older. And in October, the age indication was expanded to include children 6 months of age and older. Realizing still that the dose volumes for that particular product for 6 through 35 months of age was 0.25 ml, and for children and adults 36 months and older, the 0.5 ml dose. Note now that there are 5 inactivated flu vaccines licensed for children 6 through 35 months of age. Most of these products, except for Afluria, are quadrivalent. And there are 2 of these products. The GSK products are at the 0.5 ml dose currently. The remaining products are at the 0.25 mLs. This is for the youngest kids, 6 through 35 months of age. The dosing for persons aged 3 and older is 0.5 ml for all inactivated products. So today's agenda overview, what we're going to be talking about, this is a rather brief agenda for flu. Our 2 talks. We'll hear the talks that were presented to the work group, the influenza vaccine effectiveness in preventing influenza-associated hospitalizations during pregnancy, and that'll be presented by Dr. Mark Thompson, and then that'll be followed by a presentation from Sanofi Pasteur looking at Fluzone quadrivalent, a 0.5 ml dose for children aged 6 through 35 months. So, Dr. Thompson.
Hi, everyone. So I'm presenting on behalf of the Prevent Network and the Influenza Division on the effectiveness of the influenza vaccine in preventing flu hospitalizations during pregnancy. So as all of you know, pregnant women are believed to be at increased risk of severe disease, including hospitalization. This was a prime driver behind WHO making pregnant women their priority group for influenza vaccination programs around the world. But so far, less than half of the WHO member states recommend influenza vaccinations. A lot of those come with trimester restrictions. Vaccine is still contraindicated in many countries, including China, for example. And even in high-income countries, the vaccine is underutilized. Good news is that with RCTs and observational studies, we have growing evidence that the vaccine reduces by about half the risk of mild to moderately severe disease. The bad news is that, as WHO and others have pointed out, it's the reduction of risk of severe disease that is most valued by low and middle income countries and organizations like Gavi and other decision makers. And this gap is going to be hard to address with RCTs and existing platforms, both for ethical and feasibility reasons. So a couple of years ago, we decided to try to form a network of integrated systems that can pull together lab and medical records and vaccine registries. We call the organization Prevent. And I should say the publication from this just came out a little over a week ago, so I'll save you from reading the paper maybe, and give you a few bonus tracks too. And so we pulled together actually over 24 organizations in these regions and countries. In Western Australia and Alberta and Ontario, Canada, it was public health organizations that had the best integrated systems. And then in Israel and the US, it was the integrated care systems, the Klindit, HMO in Israel, and then Kaiser Permanente on the West Coast that participated with us. And so all these organizations went back and looked for records going back to the 2010-11 season. Most were able to look up through the 2015-16 season. And together, we had roughly 25 study season sites to look at. So we started with all these organizations going back and forming a retrospective cohort of pregnant women, which was defined by live or stillbirths with gestational ages greater than or equal to 20 weeks, and focused on hospitalizations with what we called ARFI, so acute respiratory or febrile illness. So this captures all the pneumonia, influenza, acute respiratory codes that we typically look at, but also febrile only, sepsis-like presentations and other acute conditions that have been associated with flu hospitalizations in adults. And we had to rely on, of course, clinician-ordered PCR test. In most of these organizations, the PCR used in clinical practice had gone up after the pandemic. There actually was not a lot of rapid or other tests used in these settings, but those with that were excluded. And as in a lot of clinical settings, there's not a lot of A subtyping. So what we'll focus on today is really VE against all circulating strains. And of course, did a pretty good job of having good vaccine capture, but excluded some who we lacked those records or vaccinated close to admission. So as all of you have heard many, many times about the test negative design, which is the currently established method for observational studies of VE. But here, the cases are your PCR positives, and your comparison group are those who are PCR negative. This is believed to minimize bias due to access to vaccination and healthcare seeking differences. In our study, we adjusted for site, season timing, and the presence of high-risk conditions. These are the typical adjustments in this sort of model. They were also associated with flu positivity and coverage in our sample. There were a number of other things that were associated with flu positivity and coverage that we also looked at, but did not include in the model because they didn't substantially change the estimate. So with just a few exceptions, almost all these sites and seasons were able to establish this cohort year-round. So one of the first things that jumped out is that among over 2 million pregnancies across all this time, 84% of the pregnancies overlapped with flu season. So most of this is intuitive and obvious, but it is striking to see that it's that large percentage of pregnancies that are affected by flu in one way or another. So, but then from there, you go down to hospitalizations that occur during flu seasons, over 587,000 of those. And of those, a subset of about 19,000, or just 3%, actually had one of these acute respiratory febrile illnesses. So, we're going to stay with that little sliver there for a second and talk about what made up those hospitalizations. So for most of these, the ARFI diagnosis was not the primary reason the woman was hospitalized, only 15%. When that happened, about 19% of them were PCR tested, and we found flu in 64%. Not surprisingly, when ARFI wasn't the primary driver of the hospitalization, there was lower testing, so 3%. But here too, you have a large percentage, so about half, that were flu positive. So in these hospitalizations, 67% of them were ARFI identified at delivery. So a third were not delivery associated. Again, perhaps not surprisingly, when ARFI was not associated for delivery, 14% were tested and 60% of those were positive. Much less testing if a delivery was going on, but when it was tested, again, about half were positive. So I won't belabor this point, but any way you looked at it, there were differences in who was tested and not. But when these pregnant women were tested, we saw a lot of flu, no matter how you cut it. Well, I'll return to that point later. But for now, the VE study focuses on this subgroup of those 19,000 ARFI hospitalizations where clinical testing occurred. So that's only 6%. So this is a subgroup. And once you collapse some hospitalizations that were relatively quick readmissions and treated as the same event, we're talking about a little over 1,000 events. And all but 25 of those events are with unique women. So there were a few that were repeated hospitalizations, but for the most part, we'll talk about these as women, even though the unit is actually hospitalizations. So most of these events, these PCR-tested hospitalizations, were among women under age 35 in their third trimester who had no high-risk medical conditions. Captured over 598 flu positives. This graphic shows per season the results of the testing. The grays are the negatives, the light blues are A's. So 83% of the viruses we're looking at are A's, and then some B's in yellow there for good measure. So H1N1 was prominent in about half the seasons. H3 was prominent in over 70% of the seasons. So looking at the 58% positivity among these hospitalizations, so flu was more likely to be positive in the third trimester if it was a pneumonia or influenza diagnosis, and if the primary reason they were there was for ARFI. Influenza was less common when there's a high-risk medical condition, when there's a pregnancy complication or delivery. As I already said, even in these groups, it was still pretty common. And so across sites and seasons, about 16% were vaccinated. This varied across seasons and across sites. Not surprisingly, the USA had the highest vaccine uptake compared to other sites. And the vaccination was higher among those with pre-pregnancy, high-risk medical conditions, if they delivered in the hospital or they were diagnosed with a pregnancy complication, and lower among those with pneumonia or influenza, or if I was primary diagnosis. So with no further ado, this is the actual VE table that, again, you guys are used to seeing. So among the influenza positives, we have 13% vaccinated. Among the influenza negatives, 22%. And so after you adjust for the site, season, and timing and high-risk medical conditions, that gives us a VE of 40%. And in the paper, it goes exhaustively through the various stratifications. So this number varies by site and season. The U.S. number actually was higher, so it was actually 55%. And when you take out that Southern Hemisphere 14 or Northern Hemisphere 14-15 season, where typically everybody agrees that was a poor vaccine match year, the VE goes up also. But again, in the paper, you'll see really any way you cut it, this overall 40% number is pretty stable across season timing, by high-risk medical conditions, by pneumonia, by trimester. It was actually significantly higher if the primary reason the one was for ARFI. So strengths. So the good news here, we used PCR, had good vaccine registries. We used the test negative design. And the takeaway is this is, the average performance of the vaccine across multiple countries, across a real mixture of seasons with different viruses and circulations during years where the vaccine was a good match and maybe less of a good match. And it's similar to actually recent meta-analyses looking at against flu hospitalizations with working age adults in general. So limits, obviously when you're doing clinical testing, there are lots of caveats with that. And obviously we'd love to have this data for low and middle income countries, and there's limits to the generalizability of that. I will say, when you limit, the issue here is threshold of care and severity. In our study, when you limited it to ICU admissions, so by any yardstick, a severe event, the VE was very similar. So, and then lots of caveats about any time you pull a VE analysis and we're not able to look at A subtyping or the virus match or mismatch numbers. And then registries, also imperfect. But typically, we're not as concerned about that as long as it's not systematically related to case status. So again, 40%, we think this is a pretty conservative number, looking forward at what we would expect of the vaccine in the next 10 years. It's also consistent with other studies that have come out, perhaps lower than the Malawi RCT, close to the South Africa RCT, very similar to the study CDC did with Kaiser Northern California and Kaiser Northwest, looking against symptomatic but non-hospitalized flu with PCR several years ago. So that's reassuring. And the hope is this actually gives us additional rationale for maternal vaccination programs around the world. And the final point being that, and hopefully others will pick up where we left off here, but is the substantial, perhaps hidden burden here. That over half of the flu we're finding was not the typical PNI diagnoses. There's a lot of flu with deliveries. I know absolutely nothing about pregnancy, but can imagine that all things being equal, it'd probably be good not to have flu when you're having to deliver. And finally want to thank all the experts and many players that are involved in putting this together. Thank you.
Great, thank you so much. Do we have any questions about the study before?
Yeah, hi, Mark, great presentation. Two questions. I didn't know whether you mentioned early deliveries and the relationship to early deliveries, and do you have any information on prior vaccination in prior seasons?
Yeah, hi, Peter. So we are looking at birth outcomes and are going to publish that. Nothing really super striking from it so far. We did not have prior vaccination data consistently across these sites, and it is definitely true that in some of those seasons, it would have been good to have that data because it modified VE and ambulatory studies. So that is another limitation, yes.
Great. Any other questions? Thank you so much. Oh, sorry, Dr. Newsel.
Okay. Kathy Newsel, IDSA. I was just going to comment. Beautiful study. You're right. These are the data that we need. And if we look at the MADI study, for example, we reduced influenza in pregnant women by about 50%, but we also had an impact on pneumonia in infants. So if we're really looking at the totality here, you've presented part of it.
Yes.
But there is also protection afforded to the infant against severe disease.
Yes, excellent point.
Thank you. Okay, we're going to move on to the next session. I'm so sorry.
Okay.
Dr. Monica Mercer, please.
All right, good morning, everyone. It's my pleasure to be here to share with you results from our GRC 88 study. And this was a study that, the purpose of the study was to characterize the safety and immunogenicity of the 0.5 ml dose of Fluzone quadrivalent vaccine in children aged 3 to 35 months of age compared to the 0.25 ml dose that had already been licensed in this age group. As you are aware, children are at increased risk. Oh, I'm sorry. How about moving the slide across? Children are at increased risk of influenza and illness and influenza-related hospitalizations. And for more than 30 years, influenza vaccines for children under the age of 3 have contained a half dose of antigen, so that's been 7.5 micrograms of hemagglutinin per strain, to reduce the risk of fever or febrile convulsions that were associated with earlier whole virus vaccines. But with the introduction of the split virus influenza vaccines, which are less reactogenic, we've most likely eliminated that need to use a reduced dose in this young age group. And recent studies have actually shown us that a full dose can be used in children under the age of 3 without increased risk of fever or other systemic injection site reactions. These studies have also demonstrated that a full dose of flu vaccine did induce immune responses that were generally higher than those that were seen with the half dose, and without materially impacting on the safety of the vaccine. So accordingly, full dose influenza vaccine is now recommended for children 6 months through 35 months of age by health authorities in Canada, in the United Kingdom, in Finland, and more recently in the US. With that said, the aim of GRC 88 was to describe the safety and immunogenicity of a full dose of Fluzone quadrivalent vaccine compared to a half dose of the vaccine in children 6 through 35 months of age. The primary objective of the study was to assess the safety of the full dose, which was done by comparing the rate of any fever, so that was defined as a temperature of greater than 100.4, in subjects who received the 0.5 ml dose of Fluzone vaccine to those receiving the 0.25 ml dose during the 7 days following vaccination. The secondary objective of the study was to evaluate for immunogenicity, and so that was comparing the full dose to the half dose. And immunogenicity comparisons were based on geometric mean titer ratios and seroconversion rate differences. So the study was a phase 4 randomized, observer-blinded, 2-arm, multi-center study, which was conducted in the US. The targeted subjects were 2,190 children aged 6 through 35 months of age to be enrolled. And they were enrolled. Following enrollment, we used an automated system to randomize them 1-to-1 to either receiving a half dose, which was designated as group 1, or a full dose designated as group 2. Enrollment was also stratified by age, so that approximately half of the subjects were aged 6 through 23 months of age, and then the other half were 24 through to 35 months of age. We also had a subset of subjects, 1,600, who were randomly selected to participate in the immunogenicity assessment. The investigators, the study site personnel, the sponsors, and the subjects were blinded to their group assignment. Only the study staff who were actually administering the vaccines were unblinded, and they did not get involved in capturing any safety data. In the next 2 slides, I will describe the safety data and how we got the sera on these patients. So for subjects who are receiving 1 dose of vaccine, so that was per ACIP guidance, they would come in at visit 1, were consented, and if they were randomized to the immunogenicity subset, they were then, a blood was drawn. They were then vaccinated with their designated dose of vaccine, and for 20 minutes were observed for any immediate reactions. The subjects were then, the parents or guardians were then given a diary card so that the children could then be evaluated for the next 7 days for solicited reactions. So along with the diary card, they also received a digital thermometer and a ruler, and that was so that they could record daily temperatures, they could measure any local reactions, and they could also record in the diary card any medications that were given for adverse reactions, any healthcare provider contact, or any hospitalization. So that could all be captured. The parents or guardians were contacted on day 8 to remind them to make sure that the diary cards were filled in. And then at the 28-day visit, which was visit 2, they would return with the diary cards. During that time, also, any unsolicited adverse events were captured, and serious adverse events were captured for the duration of the trial. And this is for subjects who received 2 doses of vaccine, so it's a very similar format, same procedure for each of the vaccinations. If we just go then to visit 3, which was 28 days following the second vaccination, at that point the second blood was drawn. So the study was conducted between September of 2016 through till March of 2017. Due to lower than expected recruitment, 1,950 participants were enrolled in the study instead of the planned 2,190. However, the study remains sufficiently powered for both the primary and the secondary objectives. The participants were randomly assigned in nearly equal proportions, so for the half dose or the full dose. There were 3 participants that were randomized in the half dose group, and 6, I'm sorry, I think I got that the wrong way around. 6 in the half dose group and 3 in the full dose group who were randomized but did not receive a vaccine. So that left a total of 1,941 subjects in the safety analysis set. And about 3/4 of those subjects were randomized to the immunogenicity subset. 715 participants were in the half dose group and 745 were in the full dose group for that immunogenicity subset. The study was completed by 90% of the participants, and the most common reasons for participant discontinuation was a voluntary withdrawal, not due to an adverse event or non-compliance with the protocol. There were no participants that discontinued the study for an adverse event or a serious adverse condition that was related to vaccination. At enrollment, there was also nearly equal proportions of males and females included within the full and the half dose groups. And the mean age of the participants was the same between the half and the full dose groups. And subject distribution by race and ethnic origin was similar between the two vaccine groups. So here we see the most important outcome of the study, that being the outcome associated with the primary objective, which was to compare the rate of any fever following the 0.5 ml dose, so that's the full dose, to the half dose. And the fever rate, for the half dose was 11%, and that for the full dose was 12%. In order to demonstrate non-inferiority between the two vaccine groups, the upper limit of the two-sided 95% confidence interval in fever rates had to be less than 5%. And so if I can draw your attention to the green box, you will see the difference in rate of fever for the full dose minus the half dose of vaccine was 0.84%, with the upper limit of the confidence interval being 3.8, meeting, therefore, the pre-specified criteria for non-inferiority. In terms of safety parameters, the solicited injection site reactions were captured. They consisted of injection site tenderness, erythema or redness, and swelling. And tenderness was the most frequent injection site reaction in both the half dose and the full dose groups. Proportions of participants reporting solicited injection site reactions were similar between full and half dose. And in most participants, solicited reactions were grade 1 or grade 2 in intensity, and they resolved within 3 days. The rates of grade 3 reactions, which are indicated in orange, were generally similar to the full and the half dose. And there we saw that the most common grade 3 solicited site reaction was also tenderness. In addition to fever, the other solicited injection site, did that not progress? There we go, reactions consisted of irritability, abnormal crying, drowsiness, loss of appetite, fever, and vomiting. And rates of these reactions were again similar between both groups. Similar to what we observed for the solicited injection site reactions, most systemic reactions were also of a grade 1 or grade 2 intensity, and they also resolved within approximately 3 days. The most common grade 3 solicited reactions were irritability and abnormal crying, and grade 3 fever was reported for 0.6% of participants who received the half dose and 1.2% for those who received the full dose of vaccine. With regards to immediate unsolicited adverse events, so those are what occurred within the first 20 minutes after vaccination, there were 2 in the group 1, so that's for the half dose, and there were no subjects in group 2. Overall, the unsolicited adverse events trended slightly higher in group 1 subjects than they did in group 2, and there were almost even numbers in both groups that experienced at least one unsolicited adverse reaction after vaccination. And for that, the most commonly reported adverse reaction for group 1 was diarrhea, cough, and rhinorrhea, and in group 2, cough and rhinorrhea. No subjects discontinued the study due to an unsolicited adverse reaction. There were 2 subjects in group 1 who discontinued due to other adverse events, and 1 subject in group 1 that discontinued due to a serious adverse event of pneumonia. There were no subject discontinuations in group 2, and none of the discontinuations were associated with or related to vaccination. There were a total of 5 subjects in each group that reported an SAE throughout the study. 1 of those was considered related to the study vaccine. That was a case of chronic urticaria in group 1. The event was also considered an adverse event of special interest, but there were no deaths reported in the study. Now moving on to the immunogenicity assessment. This graph represents the post-vaccination GMTs, or geometric mean titers, among subjects who received the 0.5 ml dose of Fluzone Quadrivalent, which is represented by the orange bars, versus those who received the half dose, which is represented by the blue bars. For all 4 strains, the 0.5 ml dose or full dose induced higher GMTs compared to what we see for the 0.25 ml dose. Non-inferiority with respect to GMTs was considered to be demonstrated if the lower limit of the two-sided 95% confidence interval of the GMT ratio was greater than 0.667 for each of the 4 virus strains. And so if you look at the table, you'll see that this was met for all 4 strains. Comparing seroconversion rates induced by the half dose by the full dose, compared to the half dose, we see that the full dose induced responses that were slightly higher than those observed by the half dose. And for non-inferiority with respect to seroconversion rates, those are considered demonstrated for all 4 strains if the lower bound of the 95% confidence interval around the difference between the full dose minus the half dose was greater than negative 10%. And here you can see that the non-inferiority criteria with respect to seroconversion rates was met for all 4 strains. So in conclusion, study GRC 88 affirmed that a full dose of Fluzone Quadrivalent has a safety profile that is similar to that of a half dose and may be more immunogenic. A note of these findings is that they are consistent with other studies that have looked at safety and immunogenicity of a full dose versus a half dose. Sanofi Pasteur has submitted a supplementary biologics license application to the FDA to permit use of the 0.5 ml dose of Fluzone Quadrivalent vaccine in children 6 months of age and older. The age then and the action date for that application is in Q1 of 2018. And just some safety information around the vaccine and also the indications. And so with that, I thank you. And if there are any questions, I'd be happy to answer them.
Great, thank you so much. We'll start with Dr. Atmar.
I have a couple of questions. One, for the non-white participants, there were about 25%. Do you have that broken down further into Black, African American, Asian, other groups?
We actually don't have that broken down. We do, but I don't have that. We don't have substantial numbers in that. The way we did our analysis was either white or non-white.
And you, for the immunogenicity analysis, you showed a non-inferiority analysis. Did you also do superiority analysis?
Thank you for that. So we did not perform we did not formally statistically do testing for superiority because it was a non-inferiority study. But to answer that question, we looked at if we had to use the same criteria that we used for our high-dose study, which looked at the lower bound of the two-sided confidence interval, in which then the GMT ratios had to be greater than 1.5 for 2 of the strains, then we did not meet superiority for this study.
Thank you. Dr. Walter?
Yes, you report on fever in the first 7 days and the difference between the 2 groups. Did you take a look at the first 2 days when you would expect most fever and look at that separately?
We did, and we did see more fever in the first 3 days.
And was it different between the 2 groups at all in the first
so
3
it
days?
was, when we looked at that, we did see more reactions in the younger cohort that received the 0.5 ml dose.
Great. Any other questions? Thank you so much. I think we will move on to, we have a couple of short work group updates. The first one being to introduce, I'm so sorry. Was there one more question in the back? I'm sorry, Dr. Schaffner.
Yeah, so thank you very much, Bill Schaffner, National Foundation for Infectious Diseases. Before we leave influenza, I'd just like to tell my colleagues that the National Foundation for Infectious Diseases, in addition to, in collaboration with a number of professional societies and colleagues, has issued a call to action reinforcing the importance of immunizing people with chronic medical conditions. Obviously, we're all in favor of immunizing everyone older than 6 months of age, but these are people who get the more severe complications. We brought in a number of these. They've been distributed, I'm glad to say, so we invite you all who would like to look at this to visit the NFID website. Thank you very much.
Thank you for that update. Anything else before we move on? Okay, we're going to introduce, Dr. Fry is going to introduce a new work group that's getting started.
I believe it's still good morning. I'm going to take the next few moments to introduce you to the newly formed rabies working group. And I will tell you a little bit about our charge. The members of this working group are myself and Dr. Jose Romero. Our CDC leads include Jesse Blanton and Agam Rayo. The representative from the Division of Global Migration and Quarantine is Christina Angelo. And the Immunization Safety Office representative is Pedro Moro. You can see we have multiple liaison representatives and also subject matter experts, and we are thrilled to have them and look very much forward to working with these individuals. Our purpose and goals are to provide a forum for discussion to update the 2008 and 2010 ACIP recommendations on human rabies prevention. The members will review new and existing data and also provide individual input on topics that may inform changes in these recommendations. Our first meeting was held October the 16th, 2018. I want to just give you a little bit of information about rabies and also mention what our work has been in the past on the working group, in the rabies working groups. So rabies is an acute and fatal encephalomyelitis, but it is preventable. Greater than 200,000 persons in the U.S. are exposed to rabies suspect animals every year. Over 30,000 persons receive post-exposure prophylaxis every year. Rabies PEP is safe, it's efficacious, but the costs are high. The ACIP recommendations were comprehensively updated in 2008, and the PEP schedule was updated in 2010. In the interim, however, there's new data, and the World Health Organization has updated its recommendations. Whoops. So here we have a draft of our terms of reference. We are going to review the epidemiology and burden of rabies exposures and PEP administration in the United States. We will review the evidence-based recommendations regarding use of rabies vaccines and immunoglobulin products among various populations for topics including the pre-exposure prophylaxis schedule, the route of vaccine administration, the amount and location of rabies immune globulin, and also the timing of serologic monitoring. We also review efficacy, immunogenicity, safety, cost effectiveness, route, and location of vaccine administration and vaccination schedules for rabies vaccines for pre- and post-exposure prophylaxis. And also, we will review rabies exposure risk for the general population and by occupational and recreational groups. We will evaluate the effectiveness and cost to adhere to current assessment guidelines and ACIP serologic monitoring recommendations. We also plan to review evidence generated for new recommendations of the World Health Organization and identify where additional evidence generation may be necessary to inform recommendations. And finally, we will would like to identify areas in need of further research for informing future vaccine and immunoglobulin recommendations. This is our timeline. As you can see, we are beginning phase 3. The scope of work has been determined. The systematic reviews are being gathered. The working group has just met, and we hope to, during 2019 and hopefully early 2020, be able to begin presenting the information to the ACIP for their review and finalize any recommendations and have a vote in 2020 or 2021, early 21. So in the way of acknowledgments, I would like to recognize the CDC Technical Work Group and subject matters experts. Thank you.
Thank you so much. We have one more brief update from the meningococcal work group. Dr. Stevens?
Thank you. I want to quickly update activities of the meningococcal work group. The terms of reference have been updated to focus on specific policy questions. The issue of MenB vaccine booster doses for persons aged greater than or equal to 10 years at increased risk for meningococcal disease, and MenB vaccination in children aged less than 10 years at increased risk for meningococcal disease upon licensure of MenB vaccines in this age group. Activities of the work group include review of available safety, immunogenicity, persistence of antibody protection, and effectiveness data for MenB, MenACWY, and future pentavalent ABCWY vaccines. There is a activity including development of an updated meningococcal vaccines ACIP recommendation and report, and the group is also continues to review the epidemiology of meningococcal disease and identify areas in need of future research to inform potential vaccine recommendations. We have been reviewing new available data on MenB vaccines, antibody persistence and response to a booster dose, and also safety and immunogenicity of MenB vaccines in children aged less than 10 years. In addition, reviewing and grading evidence for booster doses of MenB vaccines for persons at increased risk. Upcoming activities are in February of 2019, a review of data and grade evaluations on MenB vaccine booster dose, and anticipated in June of 2019, full session on MenB booster doses in persons aged greater than 10 years at increased risk for meningococcal disease. And in midnight 2019, publication of consolidated ACIP recommendations and report on meningococcal vaccines, both MenACWY as well as MenB. I want to thank the working group members who are listed here, in particular two other ACIP members, Kelly Moore and Hank Bernstein, and appreciate the leadership of Sarah and the CDC team in this working group activity. So with that, I thank you.
Thank you. We're going to move on to the pertussis session. Dr. Bernstein will be telling us about this new work group.
Thank you. We are in the home stretch. So there's a new pertussis vaccines work group that has been convened. And this work group's terms of reference are to consider the evidence for recommendations that would allow any tetanus and diphtheria toxoid-containing vaccine, that's TD or Tdap, to be used for the decennial TD booster in adults, and also as tetanus prophylaxis as needed for wound management. The issues being considered by this newly convened ACIP pertussis work group will first look at the previous ACIP work group work that was discussed about repeated Tdap vaccinations in 2013 and 2014 and published in MMWR in 2018. We'll also look at and recognize that the current Tdap products are currently licensed for single use. And this new pertussis vaccine work group that has been convened is going to look at potential FDA label changes and additional programmatic changes. The agenda for today's pertussis section, first our fearless CDC leader, Fiona Havers, will review the background, the current ACIP recommendations, as well as the previous ACIP consideration for Tdap revaccination. We'll then have two of the companies that make the two Tdap products present safety and immunogenicity, and then we'll have a discussion. The question specifically that we're hoping the ACIP members and others can help us with is, should the current recommendation that non-pregnant adults receive a single lifetime dose of Tdap and TD boosters every 10 years be changed to allow any TD-containing vaccine, that's Tdap or TD, to be used for the decennial TD booster in adults? And then the second question is, should any TD-containing vaccine, Tdap or TD, be allowed for use for tetanus prophylaxis in the setting of wound management? And of course, I want to thank the multiple members of this group, including Dr. Hunter as a fellow ACIP member, multiple experts as liaisons and invited consultants, Fiona Havers as our fearless leader, as I mentioned, and of course, always need to acknowledge these active participants. Thank you.
Thank you, Dr. Bernstein, for that introduction. Today, I'm going to discuss pertussis epidemiology, the vaccines available for protection against diphtheria, tetanus, and pertussis in adults and adolescents, which include Tdap and TD, and current ACIP recommendations for these vaccines. I'm also going to review the discussions that the previous pertussis vaccines work group and ACIP had on repeat Tdap vaccinations, and the rationale for revisiting this issue now. This slide shows the number of cases of pertussis reported from 1922 to 2017. The graph shows the decline in cases after the introduction of diphtheria, tetanus, and whole cell pertussis vaccines for children in the 1940s, indicated by the DTP arrow. Note that overall, there are far fewer cases reported after vaccines were introduced than in the pre-vaccine era. However, there has been an increase in reported cases in recent decades. This slide shows in more detail this recent increase in pertussis cases in the last several decades, and also shows the introduction of new vaccines. Acellular pertussis vaccines, indicated by DTAP, were phased in the 1990s to replace the whole cell vaccines previously used in the childhood series. The adolescent and adult Tdap booster was introduced in 2005. The number of cases peaked in 2012, when we had over 48,000 cases reported in the US, the largest number in over 55 years. Pertussis has historically had a large annual variation in the number of cases, but a number of factors are likely driving the overall resurgence of pertussis seen in the past several decades, which is occurring despite high vaccination coverage in children and adolescents. I will discuss coverage and the reasons for the increase in pertussis in more detail later in the talk. To protect adolescents and adults against tetanus, diphtheria, and pertussis, there are two formulations of Tdap licensed for use in the U.S., Atacel and Boostrix. These two products contain either 3 or 4 pertussis antigens in different quantities, as well as diphtheria and tetanus toxoids. The details are shown here for your reference, but note that these are currently licensed for a single use only. In addition, there are 2 licensed tetanus and diphtheria toxoid-containing vaccines, or TD vaccines, Tenavac and a generic TD vaccine manufactured by Mass Biologics. ACIP currently recommends that all non-pregnant adolescents and adults age 11 years and older receive a single dose of Tdap, preferably at age 11 to 12 years. To ensure continued protection against tetanus and diphtheria, booster doses of TD are recommended every 10 years. The single Tdap dose can replace a decennial TD booster, but the dose of Tdap, when indicated, should be administered regardless of the interval since the last tetanus or diphtheria toxoid-containing vaccine. TD may also be recommended for tetanus prophylaxis in the setting of wound management if a tetanus toxoid-containing vaccine has not been administered in the last 5 years. In order to prevent infant pertussis, pregnant women are recommended to receive a dose of Tdap during every pregnancy, irrespective of the patient's prior history of receiving the vaccine, and regardless of the interval since prior vaccination with TD or Tdap. Note that this is an off-label recommendation. Pertussis vaccination coverage in the U.S. is variable by age group. There has been sustained high coverage with pertussis vaccinations among children, shown in the yellow and green lines. With Tdap in adolescents, shown in blue, there have been substantial increases in coverage following the 2005 recommendation, with the most recent survey showing nearly 90% coverage. Coverage for Tdap in adults is more difficult to measure, but in general, the Tdap vaccination program has not been as successful in achieving high coverage, and coverage is lower than for adolescents. This slide shows the time frame for some of the discussions of repeat Tdap vaccination after it was licensed in 2005. In addition to the discussion of Tdap vaccination during every pregnancy in 2012, the ACIP Pertussis Vaccines Work Group previously considered repeat Tdap vaccination for the general population in 2013 and for healthcare workers and other at-risk populations in 2014. Many aspects of repeat vaccination were previously discussed by the work group, and their conclusions were presented to ACIP. These aspects included the changing epidemiology of pertussis, Tdap vaccine effectiveness and duration of protection, immunogenicity, safety of repeat Tdap vaccination, the potential impact on overall disease burden, and economic impact. I am now going to summarize the conclusions of the previous work group and ACIP on these topics. The previous work group concluded that the increase in pertussis cases seen in recent decades was likely multifactorial. Improved diagnosis and reporting, as well as possible changes in circulating strains of pertussis, likely contributed. But there was also evidence that waning of protection from acellular vaccines contributed to the rise in pertussis cases. Changes in the age distribution of reported cases raised concerns about the durability of protection from the childhood series and Tdap for those primed with only acellular vaccines. For example, in 2012, emergence of disease among adolescents aged 13 and 14, many of whom did receive Tdap, emphasized the importance of better understanding the effectiveness and duration of Tdap protection, especially among children primed with acellular pertussis vaccines. The work group also examined multiple vaccine effectiveness, or VE studies, done on Tdap, many of which are listed at the bottom of the slide, and most of which were done in adolescents. The work group concluded that in observational studies, Tdap vaccine effectiveness is generally high, approximately 75% within the first year, but it wanes substantially in 2 to 4 years. This VE data was consistent with changing pertussis epidemiology. The work group also reviewed data on immunogenicity, both for initial Tdap vaccination and for repeat Tdap doses. Immunogenicity studies demonstrated that for pertussis antibodies after an initial Tdap dose, there was a rapid decline during the first year with a gradual decline afterwards. After 10 years, the concentration of pertussis antibodies, while higher than pre-vaccination levels, had declined substantially and were close to pre-vaccination levels. Of note, for pertussis, we know that antibody contributes to protection, but there are no well-established antibody levels which correlate absolutely with protection. However, the rapid decline in antibody levels was consistent with the epidemiologic and VE data that indicated rapid waning of immunity and a short duration of protection conferred by Tdap. Studies that examined a second Tdap dose, including those listed on the bottom of the slide that were reviewed by the previous ACIP work group, indicate that the immune response is similar to the first dose in cohorts boosted after 5 or 10 years after a first Tdap dose, compared with naive groups receiving an initial Tdap. For tetanus and diphtheria, there was a robust antibody response that was comparable to TD vaccination. The work group reviewed safety of a second Tdap dose in the same trials of repeat Tdap vaccination. They noted that the majority of local and systemic adverse events were mild to moderate and self-limited and were generally comparable to those after a first Tdap. Among the few serious adverse events reported, none were determined to be related to the receipt of the second Tdap. Safety profiles were comparable at the 5 and 10-year intervals. In addition, the previous work group concluded that while there was evidence of direct protection, it is unclear what impact Tdap has on herd immunity and preventing pertussis transmission. For people vaccinated with acellular pertussis vaccines, symptoms are not as severe and they are presumably less likely to transmit. However, given evidence from animal models and the lack of strong epidemiologic data indicating a herd effect, the work group concluded that Tdap had potentially limited impact on disease transmission and herd immunity. In addition, they reviewed data examining the economic impact of repeat Tdap vaccination on an adolescent cohort at ages 16 and 21. Given the higher cost of Tdap compared to TD, they concluded that repeat vaccination with Tdap would not be cost-effective under the assumptions in this model, and that the reduction in disease burden would likely be limited with a second Tdap. So in summary, after examining the available evidence, the work group in 2013 and 2014 concluded that the increased number of cases of pertussis seen in the last several decades was likely to continue, although we will likely see annual variation in the number of cases. Also, while Tdap had high initial VE, there was substantial waning of protection within 2 to 4 years. The ACIP work group also concluded that a second dose of Tdap was safe and immunogenic, but that any reduction of disease burden resulting from repeat Tdap doses would likely be limited, and that given that Tdap is more expensive than TD, the certain strategies were unlikely to be cost-effective. Overall, the work group concluded that the data did not support the recommendation for a second dose of Tdap, particularly given that any recommendation at that time for more than 1 dose of Tdap would have been an off-label use. So, why are we revisiting this issue now, and why do we have a newly convened work group? So, one of the reasons for the timing of convening the new work group is that there's been an application for an FDA label change to remove the single-use language from one Tdap product. The FDA has accepted the application, and the review is expected to be complete by January 2019. There are several more reasons for revisiting this issue. There have now been several additional studies on safety and immunogenicity of repeat vaccinations. We are also seeing that multiple doses of Tdap are increasingly common. One large retrospective review identified persons who had received Tdap and then later received a dose of another TD-containing vaccine, either TD or Tdap. It found that the vast majority of those patients had received a second dose of Tdap, and only 11% had received TD. This fits with anecdotal evidence that many emergency departments, clinics, and hospitals are no longer stocking TD and only have Tdap available. Allowing Tdap to be used for the decennial booster or wound prophylaxis would potentially be easier for providers. So the questions that we would like ACIP to address going forward is as per our terms of reference and what we'll be looking at in this new work group, is whether or not the recommendation for a single lifetime dose of Tdap followed by TD boosters every 10 years be changed to allow either Tdap or TD to be used for the decennial TD booster in adults or for tetanus prophylaxis in the setting of wound management. So after our next two presentations, we would like to hear from ACIP if there are specific data that they would like to see presented, or if they have specific options or other recommendations that the work group should address to help inform this discussion. So, thank you.
Thank you. So we have Dr. Greenberg from Sanofi Pasteur presenting.
Good afternoon, and thank you to Drs. Bernstein and Havers for allowing me to give the update of repeat vaccination with Adacel from our recently completed study. The rationale for conducting this study are as follows. As previously noted, antibody concentrations to pertussis antigens wane during the years following TDAP vaccination. Similarly, protection against pertussis wanes over time, resulting in an increased risk of infection. Revaccination would potentially boost protection against pertussis and the other antigens contained in the vaccine, tetanus and diphtheria. However, Adacel vaccine is currently indicated for only a single dose. Under various scenarios, TDAP may be more appropriate, even when the history of a prior vaccination is unclear. Examples include persons who, 1, need tetanus prophylaxis for wound management, 2, are exposed in a pertussis outbreak, or 3, are caring for or living with a young infant. By way of background, in Canada and many other countries, the Adacel label includes revaccination at 5 to 10-year intervals to boost immunity to tetanus, diphtheria, and pertussis. In the U.S., Adacel vaccine is only approved as a single dose in persons 10 through 64 years of age. For our revaccination study, 2 cohorts of individuals were recruited. First, in the U.S., we enrolled individuals who received Adacel vaccine in our pivotal pre-licensure phase 3 clinical trial TD506, which was conducted in 2001-2002. Second, in Canada, we enrolled individuals in specific provinces where Adacel vaccine was routinely administered to adolescents in school-based programs beginning in 2000. The primary goals of this study were 1, to characterize the safety and immunogenicity of Adacel vaccine when administered 8 to 12 years after the first dose, and 2, to generate data to support revision of the U.S. licensed indication to include repeat vaccination. This was an observer-blinded, randomized, multi-center study with the goals as already stated. The U.S. cohort received their first dose of Adacel vaccine 8 to 12 years previously in study TD506, and they were 21 through 64 years of age at the time of enrollment in the current study. The Canadian cohort consisted of individuals who also received their first dose 8 to 12 years previously and were 18 through 24 years of age at the time of enrollment in the current study. The participants were randomized 3-to-1 to receive either Adacel or TD vaccine, with nearly 1,000 subjects in the first group planned and about 333 subjects planned in the TD group. Adacel and TD vaccines that were used in this study have the same quantities of diphtheria and tetanus toxoids, as shown in the first 2 rows of the table. An Adacel vaccine additionally contains pertussis toxoid, filamentous hemagglutinin, pertactin, and Fimbriae types 2 and 3 shown together as Fim, with the concentrations shown here. The primary objectives of this study were, 1, to compare the seroprotection rates to tetanus and diphtheria toxoids induced by Adacel versus TD vaccine, to compare the booster response rates to tetanus and diphtheria toxoids induced by Adacel versus TD, to compare pertussis geometric mean antibody concentrations induced by Adacel vaccine versus those induced by 3 or 4 doses of Daptocel vaccine in historical trials, and 4, to compare pertussis booster response rates following Adacel vaccine induced by the first dose of Adacel among similarly aged adults in TD506. So blood samples were collected before vaccination on day 1 and again 28 days after vaccination. Participants were observed for immediate reactions occurring within the first 20 minutes after vaccination. Solicited adverse events were pre-specified on diary cards that were completed by the participants for 7 days after vaccination. Unsolicited adverse events included any other health issue occurring within 28 days post-vaccination. And finally, serious adverse events, primarily hospitalizations, were monitored for 6 months post-vaccination. Approximately 2/3 of the participants were female. The mean age was about 29 years. Approximately 95% of the participants were white, and nearly all were not Hispanic or Latino. And all of the demographic data were similar in the two groups. Now on to the study results. First, safety. Grade 1, 2, and 3 are mild, moderate, and severe. Injection site reactions are shown in this slide with the color coding shown in the legend there at the top of the slide. Pain was the most commonly reported solicited injection site reaction. There were few participants who reported swelling or erythema at the injection site. Each of these reactions occurred at similar rates between the Adacel and TD vaccine groups, and most of the reactions were grade 1 or 2 in intensity. Among the solicited reactions, myalgia, headache, and malaise were reported at modest frequencies. Fever was reported infrequently. As the injection site reactions, each of these systemic reactions occurred at similar rates between the Adacel and TD vaccine groups, and most reactions were grade 1 or 2 in intensity. There were no immediate reactions reported. Unsolicited adverse events were reported at similar rates in each of the two vaccine groups. A total of 9 serious adverse events were reported, 8 in the Adacel group and 1 in the TD vaccine group. These occurred 25 to 149 days post-vaccination, and all were considered unrelated to vaccination. And there were no deaths in this study. So switching now to the primary immunogenicity results, seroprotection rates were greater than 99% to both tetanus and diphtheria toxoids in both vaccine groups. Adacel vaccine met the non-inferiority criteria for this endpoint for both antigens, as shown in the far right column. The booster response rates to tetanus was 74.5% in the Adacel group and 81.6% in the TD group. The difference for this endpoint for the two vaccines was 7.1%, and the lower bound of the 95% confidence interval was a minus 12%, which did not meet the non-inferiority criterion, requiring that the lower bound be greater than a negative 10%. The booster response rate to diphtheria was similar in the two vaccine groups, and Adacel met the non-inferiority criterion for diphtheria. Now onto the pertussis results. Adacel vaccine induced geometric mean antibody concentrations to each pertussis antigen. It was similar to or 2 to 5 times greater than the GMCs induced by 3 or 4 doses of Daptocel in the historical studies. Therefore, Adacel met the non-inferiority criterion for GMC responses to each pertussis antigen. Addicel vaccine induced booster response rates to PT and FHA that were similar to the expected rates in this age group. However, Addicel induced booster response rates to FIM and Protactin that were lower than the expected rates, with the lower bounds of the confidence intervals not meeting the pre-specified criterion. Therefore, Addicel met the non-inferiority criterion for PT and FHA, but not for Protactin and FIM. In summary, Addicel induced tetanus and diphtheria seroprotection rates that were non-inferior to TD vaccine. Addicel induced booster response rate to diphtheria that was non-inferior to TD. And the non-inferiority for the tetanus booster response was not achieved. However, it should be noted that 100% of Addicel recipients achieved seroprotection antibody concentrations to tetanus. And Addicel vaccine induced a robust anti-tetanus GMC of about 10 international units per ml, representing an 8.6-fold increase pre to post-vaccination. Therefore, the lack of meeting the non-inferiority criterion for the booster response rate should not impact clinical protection against tetanus. Addicel induced GMCs to all pertussis antigens that were non-inferior to those induced by Daptocel in historical studies. Addicel induced non-inferior booster response rates to PT and FHA compared to the expected rates. Addicel induced booster response rates to Protactin and FIM that did not meet non-inferiority criterion. However, pre-vaccination Protactin and FIM antibody concentrations were 5 to 10-fold higher than those in the historical comparison study TD506, and therefore clearly more difficult to induce a 4-fold rise in antibody. In addition, Addicel vaccine met the Protactin and FIM non-inferiority criterion for post-vaccination GMCs, and the GMCs were 2 to 3-fold higher in the Addicel group compared to the historical Daptocel data. And finally, Addicel vaccine induced 5 to 6-fold rises of Protactin and FIM antibody compared from pre to post-vaccination. Therefore, the missed non-inferiority results should not impact clinical protection against pertussis. With regard to safety, the most frequently reported solicited injection site reactions was pain with minimal swelling and erythema. And the most frequently reported solicited systemic reactions were myalgia, headache, and malaise. The majority of injection site and systemic reactions were grade 1 or 2 in intensity, and all SAEs were considered unrelated to vaccination. So just a few final thoughts regarding the results of this study. These results indicate that Addicel vaccine should be safe and effective when administered 8 to 12 years following a prior Addicel vaccination. Data from other studies that have not reviewed today suggest that the safety is there as well for even shorter revaccination intervals. And Sanofi Pasteur is seeking approval from the FDA for repeat vaccination of Addicel vaccine. It's not infrequent that we are asked by healthcare providers if TDAP vaccination is acceptable when caring for patients who do not remember and for whom there may be no documentation whether a prior dose of TDAP was received under various scenarios such as wound management, individuals exposed to a pertussis outbreak, people who are directly caring for or living with young infants. If the FDA approves repeat vaccination of Addicel vaccine, we hope that efficiencies can be gained by not having to stock both Addicel or TDAP vaccine and TD vaccines. Thank you. Thanks for your attention.
Thank you very much. Some questions specifically about this presentation, Dr. Atmar?
Thank you, David. What was the seroprotection rates pre-vaccination in the groups, and were there differences in the geometric mean concentrations between the groups at baseline?
So for the pre-vaccination...
For tetanus, I'm sorry. For tetanus.
Okay. So for tetanus, pre-vaccination seroprotection rates at a 0.01 international unit per ml and 0.1 were 100% in both groups. And at 1 international unit per ml or greater, they were in the 92, 93% range and similar between the two groups. And then were you also asking about post-vaccination or just the pre?
No, I was asking both about what the seroprotection rates were and what the geometric mean concentrations were, whether there were differences.
Yeah, the GMCs were also similar between the two groups, pre-vaccination. Yep.
Thank you.
Mm-hmm.
So correct me if I'm wrong. After the first dose of Adacel, you still get a reduction in the seroprotective rate. When you give a rebooster, you get the same reduction. So what is there that assures us that the second dose will help us have some more effective after we repeat the dose?
Yes, and the responses, as you noted, to the second dose does increase by anywhere from 5 to 10-fold the antibody to tetanus, diphtheria, and the pertussis antigens.
But it's the same,
Right,
rapid
and then-
reduction that you have that we noticed the first dose. So if that happens again, what
Right,
advantage?
and we do not have at this time persistence after the second dose, so that's an area of interest. If it does decline at a similar rate, and I don't know if that's the case, but if it does, then I think that one would expect similar protection and waning immunity and protection. I think the primary point for me is that with the single dose indication and the current recommendations, what faces healthcare providers and what we receive as feedback is they have patients for whom they don't know which vaccine or if a TDAP vaccine had been given previously, and they feel a bit cornered because they would like to administer the TDAP they have in their refrigerator, and yet with the single dose indication and there not being any suggestion that another dose can be given and that it would be safe, they're perplexed. They don't know what to do because they might not have TD available and they only have TDAP in stock.
So I think that's a good advantage to doing that, but it doesn't take away if we do, could we have the data to see if you have the same rapid decline that you have after the first dose? I mean, it's good to know that if you have Tdap, you could use it, but we want to know also, does it actually offer any advantage repeating this dose?
Yes. So just the knowledge that it would be safe, I think would reassure many healthcare providers.
I'm sorry, can I just ask that you specify, are there specific studies being either undertaken or planned to look at antibody levels? That's what you're asking, right? So I understand it's an area of interest, but can you just clarify whether that data will be available for ACIP to consider as they consider this issue?
So with regard, for example, to persistence of antibody, duration of antibody?
Against pertussis specifically.
Against pertussis. Well, we appreciate the ACIP comments, and we'll definitely take that back and see if we can bring these subjects back for repeat vaccination. I can tell you that among the many people who received the first dose of Adacel, it was extremely difficult to find them 10 years later. So we'll certainly look for opportunities to bring them back.
Dr. Hunter?
So I have a question about tetanus levels of antibodies that are lower when you do the Tdap, correct, than they are with TD.
The quantity of antigen in the vaccine?
No, the antibody response.
So the antibody response to tetanus. So the booster response, I'm sorry, yes, the booster response rate was a little lower in the TDAP vaccine group.
So do you have any data and a model to project whether 10 years later you're still going to have enough tetanus antibody so that you wouldn't have to shorten the interval of the revaccination?
Yes, so thank you for that question. So while it's true that the booster response rate was different in the two groups, the geometric mean concentration was clearly many-fold higher than the pre-vaccination level. And pre-vaccination of that second dose, seroprotective levels of tetanus antibody were at 100%. So while the boost is measured by a 4-fold rise was a little bit lower in that TDAP vaccine group, the GMCs were as high in the TDAP as the TD group, and I would expect they're 10 years later to still have, at or nearly 100% persistence.
Thank you. Any other questions? Okay, I think if you're okay, we'll go ahead and move on to the next talk. Dr. Leonard Silverstein, please.
Good afternoon. I'm Leonard Silverstein from GSK's Clinical and Medical Affairs. I want to thank the ACIP and the CDC for inviting GSK to present our two Boostrix revaccination studies, Studies 009 and Study 012. Boostrix Study 009 and 012 were revaccination studies in which subjects who previously received either Adacel or Boostrix 9 or 10 years previously were revaccinated with Boostrix. And these studies were done to show that Boostrix could be used for the decennial immunization dose of TD and also to help inform policy. Over the next 15 minutes, I would like to show you the diphtheria and tetanus seroprotection rates, the pertussis antigen GMCs, the booster response endpoints, and also safety data. Turning to the first study, Boostrix Study 009, Boostrix Study 009 was a continuation of Boostrix Study 007, which was conducted in 19 to 64-year-olds. Both studies were conducted in the United States. Boostrix Study 007, shown on the right-hand side of this schematic, was the study which was the basis of our indication for Boostrix in 19 to 64-year-olds. In Boostrix Study 007, subjects were randomized to receive either Boostrix or Adacel. And then persistence was assessed at years 1, 3, 5, and then subjects were brought back in year 9 for persistence and also for revaccination, but with Boostrix. So the Adacel subjects receive Boostrix, the Boostrix subjects receive Boostrix, and also a control group was added that had not previously received either Boostrix or Adacel. Shown here are the co-primary objectives that I'll be sharing with you. They are D&T seroprotection rates, pertussis antigen GMC ratios, booster responses for all the antigens after a second booster dose or a first booster dose, and also persistence of D&T at years 1, 3, 5, and 9. Shown here on this slide are the secondary objectives. Included amongst the secondary objectives is the safety endpoint that I will show you. With respect to the study population, it's shown on this slide, I'd like to just spend one moment referring to how I will denote each of the groups. TDAP-B, B for Boostrix, denotes the subjects who received Boostrix initially at year 0 and then Boostrix again at year 9. TDAP-A for Adacel denotes the subjects who received Adacel at year 0 and then received Boostrix at year 9, and the control group is as I discussed a moment ago. I'd like to turn to the first endpoint, which was achieved. Diphtheria and tetanus seroprotection rates for revaccination with Boostrix were non-inferior to vaccination with the first dose of Boostrix. In the TDAP-B and the TDAP-A columns, as shown in orange boxes, over 99% of subjects achieved seroprotection at a rate of 0.1, and shown in the blue boxes are that the non-inferiority criteria were achieved. Turning to PT, FHA revaccination GMCs, they were non-inferior to Infinrix, GMCs in the infant household efficacy study. And I'd like just to spend a moment to explain that there's no immunogenicity level for pertussis antigens that correlates with protection. So efficacy of acellular vaccines can be assessed by comparing post-vaccination antibody levels in this study to those observed in a population where both efficacy and antibody levels are known and where the same pertussis antigens were used to vaccinate. This is a regulatory accepted method of inferring pertussis seroprotection. So in this study, the PT, FHA, and PRN immunogenicity was compared to the immunogenicity achieved by infants who received 3 doses of Infanrix in the German household efficacy study. And Infanrix contains the same antigens as Boostrix. As shown in the orange boxes on the slide, the subjects in this study achieved at least a 1.5-fold higher GMC level for pertussis antigens than the infants did in the infant household efficacy study, and also as shown in the blue boxes, non-inferiority criteria were achieved. Before I show the booster response endpoints, I'd like just to spend a moment to review what the criteria were. So for diphtheria and tetanus, if the pre-vaccination level was less than 0.1, there had to be at least a 0.4 increase. If the pre-vaccination titer was at least 0.1, there had to be at least a 4-fold increase. And depending upon, for the pertussis antigens, what the pre-vaccination level was, there had to be an either 2-fold or at least 4-fold increase in GMCs. This slide shows the booster response rates for Boostrix Study 09. Non-inferiority criteria were met for Tdap-B and for FHA in the Tdap-A group. What I'm going to do on the next few slides, because of limitation of time, I'm going to make several points about the Tdap-B group. The results for Tdap-A were similar in what I'm going to show right now, but due to limitations of time, I'll just show Tdap-B. If you take a look at the right-handed slide, these are the seroprotection rates that I showed you after vaccination, and the seroprotection rates for both D and T were over 99%. And if we turn to the right-hand side, where I show the increase in GMC from pre to post-vaccination, it's at least for D and T a 4.7-fold rise. And if we take a look at the pertussis antigens had at least a 5.9-fold from pre to post-vaccination. And the colors indicate which antigen it is. Turning to safety. The solicited local and general adverse events for the Tdap-B and the Tdap-A group were higher than the group that received its first dose of Boostrix. However, the grade 3 AEs, which are those little hatched boxes within each symptom area, were very low, similar between groups, and ranged between 0 and 1.6%. I'd now like to turn to Boostrix Study 012. So Boostrix Study 012 was a continuation of Boostrix Study 01. 01 was conducted in 10 to 18-year-olds. This was a study in which 3 lots of Boostrix were compared to TD. Both 01 and 012 were conducted in the United States. 01 was the basis of our licensure for Boostrix in this age range, licensure that we received in 2005. The subjects in 01 were brought back at 10 years. Those who received Boostrix in the first study received Boostrix in 012. Those who received TD received their first dose of Boostrix in 012. Shown here are the study population, also how we denote the groups. The TD group is the group that got TD at year 0, Boostrix at year 10, Tdap, Boostrix at year 0 and at year 10. We had planned to enroll 500 subjects, but we were only able to get back 165 subjects, but a sensitivity analysis of persistence was done, and there was no apparent bias based on the dropout. In terms of co-primary endpoints, again, D&T seroprotection rates and also GMC ratios. And as secondary objectives, the booster response and also a safety endpoint. So turning to the results. Diphtheria and tetanus seroprotection rates for revaccination with Boostrix were non-inferior to vaccination with the first dose of Boostrix. As you can see on the slide in the orange boxes, seroprotection rates were 100%, and the blue boxes show that the non-inferiority criteria were met. Turning to the pertussis GMCs, the GMC ratio that I discussed previously, in this study, the GMCs were non-inferior to the GMCs in the infant household study, similarly to what we saw in Boostrix 009. The GMCs, shown in orange on the slide, were at least twofold or greater higher than the GMCs in the infant household study, and also the GMC non-inferiority criteria were achieved, as shown in the blue boxes. With respect to booster response rates, non-inferiority criteria were not met. But I'd also like to show you again what I showed for Boostrix study 009. Percent seroprotection at the level of 0.1 was 100%, and the GMC fold rise from pre to post booster was at least threefold or higher for D&T. And if we take a look at the GMC fold rise for the pertussis antigens, it was at least a 6.5-fold rise from pre to post vaccination. And with respect to safety, the percent of subjects with solicited local and general adverse events was higher for the group that received 2 doses of Boostrix compared to the group that received its first dose of Boostrix. And as you can also see in the pink boxes, the incidence of grade 3 symptoms were extremely low and were similar between the groups. So in summary, Boostrix study 009 and 012 were revaccination studies in which subjects previously vaccinated with either Boostrix or Adacel were revaccinated at either 9 or 10 years with Boostrix. Both studies met primary endpoints of diphtheria and tetanus seroprotection rates and pertussis antigen GMC ratios, and as I explained, that is an accepted method of inferring pertussis seroprotection. Booster endpoints were missed. Over 99% of subjects had diphtheria and tetanus seroprotection rates above 0.1. But if we look at a seroprotection rate for D&T 10-fold higher, a seroprotection rate of 1, over 91% of subjects achieved that higher seroprotection rate. And in terms of pertussis antigen GMCs, there was at least a 5.9-fold increase from pre to post-vaccination. Local and general safety symptoms were generally higher after dose 2 than dose 1, and as we discussed, grade 3 symptoms were similar after dose 1 and dose 2. So in conclusion, Boostrix, when administered to adults 19 to 73 years of age, 9 to 10 years after previous vaccination, is immunogenic and well tolerated. Thank you very much, and I'd be happy to answer questions.
Dr. Messonnier.
Yeah, I'm just going to ask the same question I asked Dr. Friedlander. What studies do you have planned, or can you provide data to ACIP around the duration of the immunogenicity of the pertussis components?
After the second booster dose.
After the second booster dose.
It's something we'll have to take back and discuss.
Ms. Hayes?
Carol Hayes, American College of Nurse Midwives. I have a question for both GSK and Sanofi Pasteur. It's the same question for both I'm very excited that you have new data. I would like to know when you submit your data to the FDA, do you have any intention of presenting data on safety in pregnancy? That this vaccine is safe in pregnancy? And will you be submitting that to the FDA so we can remove that language from the package insert?
That is something that we are considering for the future.
Thank you. And my next question.
GSK is intending to submit an SBLA for inclusion of the revaccination data in our label.
Thank you. And my next question is, do you have any intention on the future to create a pertussis-only vaccine? Pregnant women everywhere would love you if you did.
Okay, so what I
would
can
love you if
say
you did.
is, so what we can say now is that GSK is evaluating the need for a new pertussis vaccine in light of the observed epidemiologic dynamics of pertussis, the different options that could lead to improvement of a current pertussis vaccine are under evaluation. So everything is under evaluation.
Thank you.
Thank you. Dr. Greenberg, would you like to respond to that question as well?
Yes, David Greenberg, Sanofi Pasteur. For the pregnancy indication or language, we're working with FDA on updating the label along with this submission for the revaccination based on the newer FDA guidance on pregnancy. And as far as a single pertussis antigen or single pertussis vaccine, that is something that is under consideration, and we'll have to get back to you on determination of that.
Thank you.
Thank you. Any other questions? I believe, oh, sorry, Dr. Lee.
Mostly just because it went by really quickly and I might have missed it. Could you go back to slide 12, please?
Sure, let me go back. Oh, thank you.
Oh, wow. That was fast.
Yes.
So I just wanted to make sure I understood. So I understand that there's an increase pre-Tdap-B to post, but it looks like there's also an increase in the control group. Is that
In the what group?
Is that pre-control versus post-control?
Yes.
So the difference between the two, are they significant, and why did it go up in the control group? Am I reading that correctly?
Yes, you are. So one thing is, let me look at the question another way, because it's a very good question. The two groups, in terms of their baseline GMCs, are not comparable. If you look at the GMCs over here, there is a multifold difference between where the group that had already received a dose of Boostrix or a dose of Adacel, in this case it's a dose of Boostrix, you can see how much higher, 8.2 versus 5.4, 42 versus 26, 63 versus 17.8. So that when we were looking at a booster response, we're not comparing groups that are equal. The group that received one dose of Boostrix has a higher starting point than the group that never received a dose of Boostrix or a dose of any Tdap. So immunologically, it is harder to be able to achieve the multifold booster response criteria that we set for ourselves in these clinical studies.
And is the increase in the controls related to background exposure?
Yes.
Okay.
Probably.
Okay.
It's probably all the cases of pertussis we can't prevent.
Dr. Greenberg, would you like
Yeah.
to respond as well?
Dr. Leonard Friedland from GSK, just so we can just clarify a bit more on this, the control group is receiving Tdap for the very first time. So they will have it's showing the control is having a response to Tdap.
Thank you.
You're welcome.
Sorry about that, Dr. Greenberg. Okay, well, I believe Dr. Havers has a few more slides, unless we have any other questions. No, any more?
I don't have actually any more additional slides, but we have a few minutes, I believe, to ask the ACIP members what they would like to be hearing in future sessions. As we mentioned previously, this is a newly convened work group, and these are the issues that we will be addressing. But are there specific questions or specific data that ACIP would like presented at future meetings? And are there other specific policy options or other considerations that the work group should be addressing? I'm opening up if you have any questions for me based on my presentation, or if you have specific issues that you would like to see addressed at future discussions, that would be helpful.
Thank you. Dr. Hunter?
I'd just like to second the pregnancy and pertussis-only information.
Pregnancy and pertussis-only information. Okay.
Dr. Goldman?
Thank you. So also very supportive of having the Tdap in whichever company at the 10-year to replace the TD. From a private practice perspective, the purchasing cost between TD and Tdap is negligible. So just information for the ACIP as far as what it would cost to purchase in the private sector would not make much of a difference between the two. And I think it's just much easier to give Tdap every 10 years.
Thank you. Ms. Stinchfield?
Yeah, Patsy Stinchfield, NAPNAP. I'm always curious on vaccines in the pipeline, so ending the manufacturer presentations with what's on the horizon would be helpful.
Okay. Thank you. Dr. Stevens?
Just some additional information. There was this, the issue of strains and strain variability has been and continues to be an issue, and updating us on where that stands would be helpful.
Okay. Specifically, it would be helpful for us to hear if there is, I presented data from the previous ACIP work group and the various topics that they had gone over specifically to address the Tdap, whether or not Tdap should be allowed to replace the decennial TD booster. So if there are aspects, I hear some issues about pricing or concerns, but if there are specific areas related to our terms of reference, we would be interested in hearing what you would most like to hear presented at the next meeting.
Dr. Moore?
Thank you, Kelly Moore. It was very helpful to see the information on a second dose. If there are any available data on the responses to multiple repeat doses of Tdap, that might also be helpful. I don't know if there are any available, but if there are, seeing if there's a diminishing return or if there's any other things that you wouldn't expect to see after just a single booster dose is presented here, that would be great.
Okay, thank you.
Dr. Hunter?
I would want to know whether allowing repeat Tdaps is going to actually increase the uptake of Tdap in general in adults for the first dose. Because people aren't worrying about whether they had it before and you've actually documented it. And if so, if there's any projections on if you can project at all, whether that would have any effect on epidemiology.
Okay.
Thank you. Dr. Atmar?
So you told us the previous consideration in from an economic analysis was that it didn't look like it was cost effective to prevent pertussis. But here, I mean, we're hearing that in terms of the availability of the vaccine in private practice or in different healthcare settings affects the ability to deliver it and potentially does not really change the cost, at least to the practitioner. Some economic analysis on what the impact of the change might be would be useful also.
Okay. And we have an analysis underway now that's likely could be presented at a future ACIP meeting.
Dr. Frey?
I would be interested to know if there has been a look at tolerance to these antigens and if that significantly affects any of the three antigens in the vaccine. And how often do we anticipate that this vaccine will be given in anyone's given lifetime?
That's an excellent point. Okay.
Dr. Lee?
Thank you. I would love it if we'd be able to take a look at whether or not there's any disparities in terms of epidemiology, vaccine coverage, and then also just getting an understanding of the populations that are included in the any trials that are done.
Okay.
Dr. Stevens.
I just finished international travel. I went to my travel clinic and they recommended Tdap as opposed to TD for my 10-year booster. So I think that the issue of travelers would be something also to consider in this discussion.
Travelers, okay.
Great.
Well, those are many useful suggestions. We really appreciate the feedback. And we'll be talking with the work group and forming the agenda for the next couple of meetings, but we certainly appreciate your feedback for this session. So thank you very much.
Oh, sorry, one more question. Dr. Hayes, Ms. Hayes?
Yes, Carol Hayes with ACNM. One of the things that Carolyn Bridges and I had worked on was whether or not certain states are covering Tdap in adults. It's an unknown question that no one seems to be able to answer. Most states have expanded Medicaid, but not all states. And so do we have any new data on states that are not covering Tdap in adults, which would affect pregnant women on Medicaid? And if Carolyn Bridges could snap that data out of the ethos, we would love it.
Great, thank you so much. So it is 1:05. We would. This is the end of the sessions for today prior to public comment. I would like to propose that we take a 5-minute break before public comment to give people a chance to stand up. That will still give us plenty of time. The meeting does have a fast, hard stop at 1:45. And so if you guys could quickly take a break and be back here at 1:10 to start public comment, that would be excellent. Thank you. Okay, everyone, please take your seats. I want to make sure we have the full 30 minutes for public comment. So a couple of announcements before we have public comment. First of all, I really want to extend our sincere gratitude to all the members of the public who attended and provided comment at this meeting. I know several of you traveled really far, and we really do appreciate that. We do have a considerable number of individuals signed up right now for public comment, and we do have a hard stop at 1:45. Unfortunately, some of the ACIP members have planes to catch. So to ensure we have time to hear as many individuals as possible, we would really appreciate your limiting your comments to 3 minutes. This will allow us to get through everybody and to make sure that everyone has an opportunity to be heard. We can go ahead and get started. And if you would like for me to signal you when you're about 3 minutes, I can do that. I'll actually hold up a 3 for you guys so that you guys know you're at 3 minutes. So I'm going to go ahead and announce the order. And please come up in order. So the first is Destiny Maynard, and then then Elijah Mendoza Bunch, then Hillary Simpson, Russell Myers, Lair De Vega, Aaron Osbin, Laura Simonelli, Brandy Vaughn, Tia Severino, Susan Corrigan, Jamie Lynn Juarez. So if, Destiny, are you ready?
Yeah.
Great, thank you.
Hello, everyone. My name is Destiny Maynard, and this is our son, Christopher Bunch. Born December 5th, 2003, I'm here to help spread awareness, to plead to the people who called the shots. Christopher was not your average son or child. He was special, not just to us, but to anyone who was ever fortunate enough to meet him. He was such a leader and so compassionate to life. He was an honor roll student with a GPA of 3.9. He also loved playing baseball and football. Christopher, along with his best friends and girlfriend, were beginning new journeys in their lives, high school. They all had such high expectations for this year. First dance, meeting new people, and as Christopher would say, better lunches. But all that changed for Christopher on August 14th, 2018. His friends attended high school games that he should have been at and playing in, but wasn't. His girlfriend attended her first high school homecoming dance without Christopher. All because on June 29th, 2018, I trusted my son's doctor. My son's doctor's persistent advice about the HPV vaccination. This is a preventative, he told me, and I will be giving it to my children. God, do I wish I knew then what I know now. By July 20th, Christopher was complaining of headaches. By July 31st, a sore throat and headaches. And by August 6th, Christopher was very ill and vomiting at football practice. On July 8th, we went to the local ER where we were transferred to the Iowa City Children's Hospital on August 9th. On August 10th, from a regular room to the PICU because Christopher's condition was rapidly deteriorating. On August 11th, the most terrifying thing that I have ever witnessed in my entire life, Christopher stopped breathing on his own. On August 12th, the swelling in Christopher's brain was so severe, the only option they had to potentially save my son's life was to perform a craniotomy on the right side of his skull. Unfortunately for Christopher and our family, the damage was so severe that he was pronounced brain dead. On August 14th, his father and I had to make the decision no parent should ever have to make, to unhook our baby that we had raised from life support. We will never get to kiss our boy again or hear his voice tell us how much he loves us. He will never graduate from high school. He will never get married, and he will never have children. That has all been taken from us. You voted on October 25th, 2011 to offer the Gardasil shot to boys. How does it feel knowing that your vote killed my son? I also have a letter that Christopher's neurologist wrote to us. In many cases, ADEM, the patient received a vaccination shortly before the onset of the disease, thus strongly suggesting that this immune-medicated disease is triggered by vaccinations in at least some cases. Furthermore, the human papillomavirus vaccine has been specifically implicated in several published reports. Christopher received vaccination against HPV 1 month before the onset of ADEM. Therefore, strong consideration must be given to the notation that the HPV vaccination triggered the ADEM in this case. Thank you.
Thank you.
We're so... Mr. Bunch, are you speaking as well? Okay.
My name is Elijah Bunch. As you just seen, we was up here with my son's mother, and it's affected us terribly. There was so much I wanted to say, but his mother and I kind of compiled stuff together in a short period of time. And I wanted to ask you guys, seeing that this is being broadcast live, and I'm not as smart as a lot of people here, but I want to get some words out for my son. If I could invite somebody to come up here and kind of help me speak just a minute or so, would that be okay?
Sure.
Brandy, would you come up and help me, please? Thank you.
We were told that we might run out of time today, and I wanted to go into some of the science that they had just spoken about. So as she'd mentioned, and as the neurologist mentioned in his comment, in his letter, there are multiple dozens of studies linking Gardasil particularly, but the HPV vaccine in general, to ADEM and multiple paralysis, autoimmune mediated diseases. I have 50 studies right here, and I tried to get them in the hands of the working group, but I was not told that that was a possibility. This is just a selection of over hundreds of studies, case reports, but also epidemiological studies and meta-analysis showing that there are serious health issues following the HPV vaccination, not just in the US, but all over. So, in fact, there's 60,000 adverse reaction reports to VAERS, again, regarding the HPV vaccine in the 12 years it's been on the market. There have been 432 deaths, not even including Christopher Bunch's because he's not included in the numbers yet. If this was a pharmaceutical drug, would it still be on the market? You know, I would love an answer to that question. I know you guys don't answer public comments. But Christopher Bunch should never have been sacrificed as a test subject on a vaccine that hasn't been tested properly and has shown so many adverse events. So in 2010, the HHS decided that Harvard Medical School should do a report on whether or not VAERS was being used. And according to that Harvard Medical School study, fewer than 1% of vaccine reactions are ever reported. So this is Harvard Medical School. This is not us. This is not Christopher Bunch's parents. Okay? We're giving you the information that pharmaceutical companies are not. And we may not be able to stand up there and present in a PowerPoint, which I would love to do one day. But this information needs to be looked at by every single member on the committee. So if you use this estimate from Harvard Medical School report that was funded by the HHS, that would mean thousands of children have died after this vaccine. And millions have been possibly injured. And yet this vaccine is still on the market. And the newest version, Gardasil 9, has twice as much of the aluminum adjuvant, which is in most of these studies as the antigen that's triggering the autoimmune-mediated diseases. Twice as much aluminum and twice as much of the virus as well. So I'm going to speak later on whether it even causes that. But thank you, Elijah, for giving me that time, because he wanted me to help him go over the science to show you this is not just their personal opinion.
Thank you all so much for giving us a minute and hearing our story.
Thank you, Mr. Bunch, and thank you, Ms. Maynard, for sharing your story with us. Next, Ms. Hillary Simpson.
Good afternoon. My name is Hillary Simpson. I am the founder of a nonprofit called Crazy Mothers. We work at spreading vaccine injury and recovery awareness, because that's the crazy thing. If you catch your child's vaccine injury early enough, you can recover them. You can heal them without the use of a single pharmaceutical. But enough about me, we're here to talk about you. And really, I just have a couple of quick questions. The first question is who? Who in here thinks it's okay to recommend 72 doses of vaccines to children without doing a single cumulative safety study? Who in here thinks that it's okay to refuse to do a vaccinated versus unvaccinated safety study so that we might truly be able to assess the advantages and disadvantages of vaccination? And who in here thinks that it's okay that 54% of our children are suffering from a chronic illness and 1 out of 36 of those children will be diagnosed with autism? My second question is what? What are you, as the committee working with the regulatory agencies tasked with protecting the public's health, what are you going to do about the vaccine-induced autism epidemic and the vaccine-induced autoimmune epidemic this country is currently experiencing? What are you going to do about the generation of children that we have lost? How? How are you going to continue to explain away those autism rates as they go from 1 out of 36 to 1 out of 25, 1 out of 15, and eventually 1 out of 2, which will be by the year 2032, according to Dr. Stephanie Seneff, if the numbers continue to increase at the rate they're currently at? How are you going to persuade those mothers having children 15, 20 years down the road when the vaccine injury epidemic is so blatantly obvious it becomes impossible to ignore? And lastly, when are you going to start listening to the hundreds of thousands of parents screaming from the rooftops that the vaccines injured or killed their children? When are you going to start actively working towards a resolution for this massive problem? And when are you going to stop hiding behind the "we don't know why our children are so chronically ill, we don't know why we're experiencing an autism epidemic, we don't know why"? Because we do. Us crazy mothers know, and we're healing our children. Biomedical treatments, holistic modalities, naturopathic medicine. We're healing our babies. And if that makes us crazy, so be it. Like I said, let us know when. Thank you.
Thank you. Russell Myers.
Hi, I'm Dr. Russell Myers, National Health Federation. Ladies and gentlemen, we have a problem. Clearly, there's been a disconnect between trusted health officials and those people that you serve. You say that vaccines are safe, effective. We believe you, we receive them, and when we get injured, we are ultimately ignored and told there's zero science back in the claim. This needs to be addressed somewhat properly. It is unclear to me what scientific evidence you have been reading to make the claims that vaccines are safe, considering that even the father of modern-day vaccines, who literally wrote the book on vaccines, can't defend this medical procedure's safety under oath during his deposition earlier this year. But further than that, seeing the extreme lack of proper evidence presented in this room today and yesterday is quite terrifying. All these safety studies using the word placebo when in reality it's an adjuvant containing placebo, or in some cases like the HPV ones over here, it was a straight shot of aluminium hydroxide. It's misleading to say the least. This speaks volumes to the lack of knowledge that is known and in this area, no matter how much one says that vaccines are safe. According to the Supreme Court, they are unavoidably unsafe by design defects. Your vaccine safety studies comparing those who get fewer vaccines to those who get more vaccines is obviously flawed and at worst criminal, considering the dire consequences. Your epidemiological studies have not held up to scientific scrutiny and at worst have been shown to be revised multiple times to get the desired result. Not only losing faith with the people, but losing your reputation in the process, especially when we see like the CDC testifying in Congress, blatantly unaware of any vaccine peer-reviewed studies showing how much damage they do cause. This looks more of a political issue than a scientific one. The biological studies, the mechanism of action studies of vaccine adjuvants and ingredients such as aluminium hydroxide, aborted human DNA are clear. Not only do vaccine adjuvants cause damage, it's just a matter of how much. Many of these ingredients have even been found to be neurotoxic at parts per billion by themselves, but when added to the vaccine at 1,200 micrograms, suddenly becomes safe. There's a large gap, as far as I see it, of understanding or a problem extrapolating the evidence from basic science to the clinical science realm. Now, I understand that we push vaccines under the umbrella of public health, but this is at the expense of taking lives and giving debilitating injuries like paralysis, encephalitis, myelitis, death, all without informed consent. CDC and doctors telling the parent that the only real side effect of a vaccine is the redness and pain at the injection site, whilst death and lowered consciousness is listed, is not informed consent. You have not done a good enough job to show that these things are safe. The majority of those opposed to vaccines all believed in vaccines until their child or themselves were injured at the moment of injection and would have wished at least to have been informed of the risk akin to surgery risks before they get the surgery, before they sacrifice to the medical community, then which the medical community disregards and ridicules after performing. It concerns me from what I've seen from this panel and from conversations I've had here from top vaccinologists that most people here cannot comprehend any idea on how vaccines can even cause damage. The science is clearly not settled, and from what I've seen today, not even looked at properly. Let's do this right this time, not have like another Verstraeten study incident where meetings are held in private to go over the problem that simply won't go away. Thank you very much.
Thank you. Ms. Lyra de la Vega.
Hi, Lyra, yes. My name is Lyra de la Vega. I am here representing also the National Health Federation. I don't have a vaccine-injured child. I don't have any children, actually. And it's in an environment like this, it scares me out of having children because I don't want anything like this to transpire with my child that's happened to many of these families. But I'm here to represent NHF, and I'm 100% against vaccinations, just so that you're aware. As of the beginning of October, the National Vaccine Injury Compensation Program has paid out about $3.9 billion. I don't know how many of you are aware of that. I don't know what you all are aware of much, but that was created in the 1980s, and this number continues to go up. The fact of the matter is that if safety reporting was done properly and truthfully, we would be paying out in the trillions, financially crippling our nation even more. And I say that because there's merely a 1%, as Brandy Vaughn said, there's reported vaccine adverse events. So, and I say we because it's common knowledge that amongst attendees like myself, that pharmaceutical companies are liability-free, which is criminal, and these vaccine injury payouts are compliments of the taxpayers now and have been for quite some time. Now, my comments on VAERS, the Vaccine Adverse Event Reporting System, I'm here representing the oldest health organization in the world, and we have very deep concerns about your scientific data related to vaccine safety and effectiveness. Sorry. The mere fact that VAERS even exists indicates that you all have admittedly acknowledged that adverse events do occur. And we know that they exist because we paid out in the billions, like I pointed out. And since there is a risk for adverse events, my belief is that there must be choice as to whether or not we want to take that gamble. And I say gamble because everybody's chemical makeup is completely different. And if you guys don't know that, none of us should be here. We should really be freaking out and going back to the drawing board, which we should be doing. Now, with regard to VAERS, when this panel uses VAERS post-market adverse reaction surveillance, it sounds and seems very formal and matter-of-fact, but when VAERS is actually used by us, it's basically a random free-for-all for those that are even aware of it, and the masses are not aware of VAERS, and that is very dangerous. Now, since you're all taking all of these situations as matter-of-fact post-marketing surveillance, I don't understand that this is usable data, especially because only 1% are even reported. So to say that these assessments are way off are a gross understatement. But at this point, I want to urge you all, I'm imploring you, if I can, to please place urgency on VAERS for what it's meant to be, to receive proper data, and also in making I want to make it an absolute requirement for health officials to have a vaccine adverse event safety conversation with the recipients of vaccinations, as it is their right to be aware of what horrible things can come to them. Recipients of vaccinations must be informed on what to do and who to contact, so that all of you can finally use close to factual data when making such important decisions for people of our country that are indoctrinated to trust you. You guys couldn't even determine yesterday what ultimately the definition of homelessness even was. What kind of data are we working with? I mean, you voted yes to vaccines. You're voting with data that's incomplete. It's not a fair assessment. We have no business being here right now. As far as I'm concerned, not only is the science not settled, it hasn't even been conducted. I feel like I traveled across the country from California only to watch a biased panel go through the motions, and we're at the CDC. I'm not a singular individual speaking out against vaccinations. This happens to be a movement now, and one that's growing rapidly and exponentially, and not because we love or even like each other, but because you're creating more of us every single time you vote in favor of implementing more questionable vaccinations. Thank you.
Thank you. Lara Simonelli, and I just want to remind people to please try to keep under the 3 minutes so that we can listen to everyone.
I'm a little shorter than she is. I'll try to talk fast. I don't come here with any degree. I come here as the public. I live locally. You are our one and all. I'm going to start with a quote by William Wilberforce, and he stated, "You can choose to look away, but you can never say you don't know again." I just retired from a local hospital here. No one believes in the flu shots. My colleagues, I didn't. Because the efficacy, and I won't give you data, you created the data. 10% one year, 18% the next, 40% at best. The flu mist you gave to our children from 2 to 8 years for almost 4 years, it never worked, 3%. Oh, well. You know, I worked in a hospital where my colleagues, doctors and nurses and medical assistants and patient care and lab, we didn't believe in the flu shot. We were probably at 40%. And then came your mandates. And then came your recommendations. So you know what? For 4 years before I retired, I put a mask on, 12-hour shifts. It wasn't easy to breathe, but that's how much I didn't believe in your efficacy. My colleagues didn't believe in it either, but some of them couldn't wear that mask for 12 hours. So in the beginning, they said, I'm just getting the shot. I can't wear the mask. But in the truth, the public's truth, my observation, which is the first step in scientific theory, they didn't believe in your shot. This year, I retired. I'm grateful for that because my soul was sick at what I saw go on. That flu shot was crazy. At first, it was 10%. How can you do data? Which 10 got the shot out of 100? Then it was 30. And then you get up here today and make new implications on our children and combine 4. Really? You govern globally and this country. I'm glad I'm retired now because now I can talk to you. Because you know what? While I worked, I couldn't. Because if I did, conflict of interest, I would have lost my job. That's truth. A lot of my colleagues did lose their jobs. I was one of the few hospitals in this city that allowed us to mask. I can name 5 hospitals that don't. Goodbye, pink slip, no flu shot. How did I survive 20 years and never get the flu in that environment? ER, high volume. Was I not on the front lines? Every flu case, 300 people a day. Every flu case, it was me. I never had the flu. You know why? I knew how to wash my hands. I knew how to take vitamin D. I knew how to take elderberry syrup. I don't approve of your flu shot. Now you have pharmacists giving it. You bribe us with cards at Target and you tell us this is free and it's everywhere and get it, get it, get it. They're scare tactics and you should be ashamed. And then I will end because I do want my colleagues, the other moms that know what the CDC doesn't do for us. Robert F. Kennedy Jr., he fights for us. He does. He goes to court for us, for our kids that suffered. I'm looking around. Some of you are my age. And if I'm mistaken, I apologize. But I'm in a generation where I got 7 shots. 26 years later, my daughter got 10. Her son got probably 60. My new grandson's expected to get 72, and I just watched you add more. I'm appalled. Robert Kennedy Jr., you know what he says? His family started Special Olympics. There were no autistic kids. He says that where are the 40-year-olds wearing diapers with helmets on at the mall if you misdiagnose them, if you miss them, because you say they're not vaccines, that they missed them. Where were the special ed classes when people in my generation, there weren't any because they didn't exist. That's what he says. Do you know, and it's truth, but you know what's going to happen? I have a 10-year-old grandson, and I don't care what you say, that the autism and vaccines don't exist. It does, because I watched a perfectly healthy, beautiful 2-year-old get those shots and become a severe autistic child. And guess what? He will be 40, walking in the mall with a diaper on and a helmet. Thank you for the studies that you don't do.
Thank you.
Ms. Brand-Davon.
Hi. So a little bit earlier, I gave you the statistics on the VAERS results for Gardasil. I'm going to talk a little bit more about it and about the science about what's going on here. It's clear that this vaccine, Gardasil, is harming more children at epidemic proportions. So what are the benefits? Why would you add it to the adult schedule? I mean, the science is slowly showing, does HPV even cause cancer? There was a great study out of the University of Berkeley by a well-known professor, Peter Dunsberg, that showed cervical carcinomas are not caused by the HPV virus. It is a passenger virus, a latent virus. We all have latent viruses in our body. Because it's in a carcinoma does not mean it caused it. So, quoting him, He says, since there is no scientific evidence that it will do anything else, HPV, will do anything else than occasionally cause warts, which will be eliminated by the immune system, there is absolutely no need for vaccination against this virus. His basis for this perspective was an in-depth study that he did in 2013 with colleagues from University of California, Berkeley. And it was published in Molecular Cytogenetics under the title Individual Karyotypes at the Origins of Cervical Carcinomas. He is one of the leading experts on cervical carcinomas in the world. And the study states there is no direct functional evidence that cervical carcinomas depend on the latent papillomavirus viral sequences. So not only does evidence show that the HPV is not the real cause of cervical cancer, newly released cancer data, cervical cancer data, out of countries that implemented the HPV vaccination at more heavily than the US, so the UK, Norway, and Sweden, are all showing increased rates of cervical cancer in the population that was vaccinated, up to 90% in the UK. This is not happening in the older populations. I have the numbers and I have the research here. So, in Norway, before the HPV vaccination, cervical cancer rates had fallen sharply, but since widespread HPV vaccination campaign in 2009, cervical cancer rates have increased and nearly doubled between 2004 and 2015. Doubled. The rate continues to trend upwards. We're looking at a vaccine that is actually causing an increase in cervical cancer rates. So, what happened in the UK? The youngest group age reported for cervical cancer rates that's tracked by the government, 20 to 24. The change before and after the HPV vaccination campaign, which covered 90% of girls, began, it's shocking. And this should cause every single one of you to rethink this push to have girls and boys, like poor Christopher, vaccinated for HPV. So between 2002 and 2009 in the UK, the last year before the vaccination campaign started, cervical cancer incidence decreased 40% in girls aged 20 to 24. It decreased 40% before the vaccination campaign. In the 6 years directly before the campaign, in 2009, the year the vaccination school campaign achieved 80% coverage rate for girls 12 to 18, the incidence decreased, it slows, and then stagnates. So it was going down and then it stagnates. By year 2011, cervical cancer begins to increase in girls aged 20 to 24 only, not in older populations. These are the girls that were subject to the vaccination campaign. This trend is so pronounced. Between 2012 and 2015, cervical cancer rates increased 45% in the population that received the vaccine. Increased 45%. Older women did not show an increase. So, how did it happen? I'll be brief. Please. This 2012 study by Dr. Lee, published in Journal of Inorganic Biochemistry, shows the mechanism of action. The HPV gene binding to the particulate aluminum adjuvant in the HPV vaccine. So it's taking aluminum to the reproductive area because HPV is a reproductive virus. And it is possibly the mechanism of action that is creating the increase in cervical cancer risk. So when you vote to add this to the adult schedule, you are voting to increase cervical cancer in this country for a vaccine that is causing widespread side effects and has never been proven to reduce cervical cancer rates, not even proven to reduce one case.
Thank you so much. We really appreciate it.
So please, vote no to add it to the schedule, and please do the studies and pull this off the market. Thank you.
So we only have a few more minutes for public comment. I would really like to know if there's anybody who hasn't spoken yet, who we would like to hear from. Ms. Hawes, have all three of you
I will
spoken
be
in the
brief.
past? Okay, thank you.
I said quite a bit yesterday, so.
Great.
Hi, I'm here as a member of the public. I'm also an engineer with my master's in engineering. And I've been here over the past 2 days just observing the studies and looking at the work that you're doing. And I've seen a lot of competent scientists and a lot of wonderful physicians who are doing great work. But I did have a couple of concerns that I wanted to raise. The first concern is that the studies I've seen are very linear in nature. You're given the subjects are given the vaccine and then immediately measured to see how much their immunity increases. My concern with this is that that you're assuming that these vaccines don't have consequences later on down the road. I would really like to see you direct more money towards studies that look at the long-term consequences of these vaccines. My second concern is prioritization. As I've sat here, I've seen that you looked at Japanese encephalitis that affects people that go to the Philippines for over a month. And while in our country we have children that their autoimmunity is being damaged by the day, and I hope that you will reprioritize. Thank you very much.
Thank you so much. Ms. Severino?
Thank you. I said a lot yesterday, so I'm going to make this very brief. I have 2 lists to read you, okay? I want to start with a quote by Dr. William Thompson, who is still employed here at the CDC. I'm sure you all know who he is. Dr. Thompson said, "Here's the deal. The CDC, they're paralyzed. The whole system is paralyzed. And the whole branch is paralyzed, and it's becoming more paralyzed. There's less and less being done as the place is coming to a grinding halt." He was referring to autism. Autism seems to be paralyzing the CDC, and he should know. So I just want to read you a quick list here. These are the theories of autism causation. Started off, it was refrigerator moms. That was a good one. Then there's the genetics, better diagnosis, toxins, but not from vaccines. This one's good. Advanced paternal age. Okay. Wireless exposure. Rubella in pregnancy. Biological, encephalitis, untreated PKU, pesticides, herbicides, heavy metals, but not the ones in vaccines. Viruses, again, not the ones in vaccines. Bacteria, but not the ones from the vaccines. Low oxygen at birth. Chemicals, just not the ones in the vaccines. Prematurity at birth, but hey, go ahead and vaccinate your premature baby at the same schedule as if they were born full term. That's a good one. Neonatal exposure to environmental toxins, but not the ones in the vaccines that you give to pregnant women. Phthalates exposure in pregnancy. Oh, living in cities. Higher income parents. Basically anything but the vaccines. And I'm here representing a lot of families who could not be here, as you know. And you met yesterday my friend Priscilla and her husband Will, who lost their daughter Willow after her 4-month vaccines. So I have a list of deaths from vaccines. Because yesterday we heard from Paul Offit and his friend about the lovely lady who started the meningitis B vaccine campaign, which seems to be kind of like, it kind of makes me think you guys are copying, like they're copying the anti-vaxxers, but never mind that. Nobody likes to see a child die from a disease or anything, okay? I wouldn't wish meningitis on anybody. I certainly wouldn't wish a death on from meningitis on anybody. But because this baby died, all kids have to have the meningitis B vaccine. That's interesting. So let's talk about it. Daniel Ramirez went for his kindergarten shots and died. Ryan Labrie had his DTP vaccine and died. Rose Haas had the HPV vaccine and died. Nicholas Catone had the DTaP in his infant vaccines and died. Marshall Thomas had the flu shot and died. Zara Shiel, and I'm probably not saying that last name right, went for her 16-month vaccines, dead. Holly Stavola had the MMR, dead. Kyle Dale Mowry at 3 months, dead from his routine infant vaccines. Kelly Michelle Hall at 2 months, DTP, dead. Colton Barrett had the HPV vaccine because the doctor told him he would be protecting his future wife. Athlete, paralyzed on a respirator, committed suicide because he couldn't go on that way. Eric Prine had the DTP vaccine. He suffered over 100 seizures before he died at 22. His father spends countless hours online trying to spread the story of his son's death. And finally, Mason Bundy, who when he was 4 months old his mother was told by a doctor, if you don't get this vaccine, you are signing his death certificate. Yeah, less than a week later, they were signing his death certificate. He would have turned 8 on Monday. If I had given my son the full barrage of the CDC recommended schedule, because I told you he's had 4 single dose, spaced out vaccines. If I had given him all of the vaccines, the way that they are routinely administered to infants, he would be on this list. He certainly wouldn't be sitting here today. And if he was alive, he would be so severe that there's no way that I could be sitting here listening to you and talking to you. Please, any death of any child is tragic, but you cannot ignore these deaths anymore. They are just as important as a baby who dies from whooping cough, meningitis, or any other vaccine preventable disease. Okay? Thank you very much.
I'd like to
Thank
point
you.
out that the committee needs a timer. I've been to thousands of hearings and committee meetings, and there's usually a timer.
Thank you for that
So are you going to
feedback.
end this, or are we going to be allowed to finish our public comment?
I did say that we had to end this at 1:45. Is there anybody who has not had the opportunity to speak who has signed up for public comment? I have Susan Corrigan and Jamie Lynn Juarez, and then
And we spoke, and
I've
I also
Kathleen.
suggest cameras because we have Dr. Paul Offit on camera shooting himself in the head while a mother of a very sick child who was giving public comment was mocking, and that's not okay.
Thank you. So we have one final, I think we unfortunately have to end public comment. Everybody who has come has had an opportunity to speak, is that correct?
Yesterday, I wasn't able to read my comment because of just being a little overwhelmed. Mine's
Okay.
about 13 sentences.
Please go ahead. Thank you.
I will go quickly. Thank you. Susan Corrigan, Seattle, Washington. FDA recently approved Gardasil 9 for men and women 27 to 45, so the age range recommended for this vaccine now spans 9 to 45. FDA's decision to expand to older adults is concerning, given that FDA originally refused to approve Gardasil for this age because there was insufficient evidence of the vaccine's effectiveness. In the older women, FDA also noted increased risk of non-vaccine type-related CIN2 or greater, but Merck erases disease enhancement risk in the long-term follow-up by vaccinating the controls and then comparing those originally vaccinated versus later vaccinated women. Please see page 8 of the recent FDA approval document showing how Merck and FDA compared only vaccinated against vaccinated to mask any risk. Additionally, in another Gardasil trial of 16 to 26-year-olds, the FDA recognized that the vaccine actually increased the risk of women developing vaccine type-related CIN2-3 or worse by 44.6% if a woman had been previously exposed to vaccine-related HPV types and currently had an infection with vaccine-related type. Based on these disease enhancement signals, we are extremely concerned that this new recommendation for older adults is more likely to have HPV exposure, will increase a woman's risk for cervical disease, and perhaps even cancer from both vaccine and non-vaccine HPV types. While this data should have supported doctor screening for HPV infection before vaccinating to reduce risk, the American College of Obstetricians and Gynecologists instead actively discourages pre-screening. Moreover, FDA approved Gardasil 9 for men aged 27 to 45 based on inferred efficacy for women in an incredibly small study in men, which is insufficient to recommend a blanket approval for all men in this age range in the United States. An immediate investigation is warranted, as we do not believe that the FDA examined this issue with close enough scrutiny. Thank you.
Thank you so much. Okay. I believe that is all, and the meeting is officially adjourned. Thank you all for being able to stay the extra couple of minutes.
And I'm ashamed of our military.
And we will see you all in February. Thank you.